Shekhar Nimbalkar from Karamsad, Gujarat. We have Dr. Anjali Oti from Mumbai. We have Dr. Geeta Bhatt from Mumbai. We have Dr. Manish Doshi, who is a joint zonal coordinator for IAP ALS group. He's joining us from Thane. We have with us today Dr. Manish Jain. He's a well-known figure in Nagpur region, and he's a faculty for ALS since very long. We have Dr. Sagar Lad, who is a newcomer to our group, but he's a well-known figure in Maharashtra advanced life support. We have Dr. Nivedita. Dr. Nivedita is from Kolhapur, and I thank her for being here as a master projectionist for today's course. It takes a lot of efforts to conduct a course on virtual platform, and all of us have to come forward. So I congratulate Dr. Nivedita for coming over here. Dr. Vaswani ma'am from Mumbai. She's a senior consultant and a well-known figure in IAP ALS West Zone group. And we have Dr. Sandeep Golhar, Dr. Swapnali, and many new faces coming in and joining in today for this prestigious workshop. I also thank Dr. Uday Bodhankar sir for his words of wisdom and joining here on the platform. And we all look forward to make it a great event. Dr. A.K. Sharma is a national coordinator of ALS, and he's one of the founder of this module. This is a brainchild of Dr. A.K. Sharma, Dr. Ellen Taneja. But unfortunately, because of some reasons, he may not be able to join. Dr. Akash is back. Is he back, Dr. A.K. Sharma?
No, we don't see. Yet.
Okay. Just a few instructions for all the delegates. Please keep your mobiles in the silent mode. Do not interrupt while the speaker is speaking. Put yourself on the mute mode of the Zoom settings. Unmute whenever when you are called on or when you need to be discussed at the end of the sessions. Then few of the things, that is like 85% score is mandatory for the post test to get a successful certificate. The post test will be released in the afternoon, and you will get a post test as a form of Google Forms. The important here is that you should be filling all the post test, pre-test, as well as the feedback forms. So if you as a delegate who has successfully joined the course, and few of the instructions will give you as and when it is required. I again thank Dr. Shubda Kirwadkar, President Nagpur IIP, Dr. Uday Bodhankar sir, all the stalwarts from the Nagpur IIP for helping us to conduct this on a bigger platform. Thank you very much, sir. Thank you. Thank you, ma'am.
Yeah, Mandar, please continue, and Dr. A.K. Sharma is not able to log in.
Mandar sahib,
Mandar, do you have a problem?
Yeah.
Looks like.
Yeah.
Mandar, you are back.
Sir.
Yeah.
Yeah, please go ahead.
I'd like Dr. Uday Bodhankar sir to say a few words of wisdom. Dr. Uday Bodhankar sir, please, sir.
Okay, good morning all. Dear Dr. Sharma, Dr. Mandar, Dr. Manish, Akash, Shubhadan, Mustafa and Meenakshi, all the guest faculty. I will not take much time, but let me tell you for your information, first BLS course of India was done in GMC Nagpur in 1988 with Dr. Vidyasagar, Dr. Vinod Bhutani, Dr. Kachi Jejik and Dr. Shukla. So this was done on the babies, stillborn babies in 1988 when I was the lecturer in pediatric medical college Nagpur. After that, the course took the BLS was taken to IIP when I became the president of IIP in 92-94. So the origin of BLS, we are very proud, Mandar, that it started from Nagpur, Vidarbha, and it went to all India. Thank you very much. We are going to listen to very brainstorming session. I will not take much time. I welcome all faculty, all delegates, and learn the thing and get academic phase to you. Thank you.
Dr. Akash. Dr. Akash?
Yes, yes, Mandar.
Yeah, we'll start with the proceedings. Doctor, I got a call from Dr. A.K. Sharma. Probably he's joining there. Has he joined?
No, not as yet.
Not now, sir. Not up now.
So,
Mandar, I think you should start.
Okay.
Start with the intro lecture.
Okay, next slide, please. So, training in advanced life support is important. The aim is to prevent the death. The process is to buy time for definitive means and prevent and treat the life-threatening conditions like respiratory insufficiency, circulatory insufficiency, neurological insufficiency, and others. The ALS courses trains us in identification and stabilization of these insufficiencies. So you can get these insufficiencies anywhere in your practice, even on the roadside also, maybe in your private nursing home also, in one doctor clinic also. So to recognize these problems as a respiratory insufficiency, circulatory insufficiency, and treating them will help us to go through this module tells us about how to get about all these emergencies and how to, the beauty of this module is that in spite of any etiology, whatever it may be, it is important that once we follow this particular tool of assessment, you will be able to reach a particular diagnosis at the end of your examination and you will treat the problem the child is suffering from. Thomas Alva Edison once said that problem well defined is half solved. So once you get the problem area the child is suffering from, the most of the things are solved. So it is very important to know what the problem area the child is suffering from. And the beauty of this course is that at the end of this course, you all will be proficient in making the tool-based diagnosis of a particular child, and whether it is an emergency, whether it is a physiologically unstable or stable child, you will be able to make it out, and then we'll have to treat it accordingly. Next slide, please. Next slide, please. Yeah. So the scope of this advanced life support is, it has to be relearned every 5 years. 70% of the healthcare in India is being providing these courses. At the government, yeah. So the government provides 3-tier services: primary level, the PHC level, and the dispensaries, the secondary level general hospitals, nursing home, polyclinics, and basic life facilities. The tertiary hospitals were the teaching hospitals and the multi-specialty hospitals. So 70% of the healthcare is provided by the private sector. So it is very important that all of us are well learned in advanced life support. Next slide, please. So when you see the healthcare pyramid, the primary healthcare facility or at the OPD clinics, a particular doctor who is an individual should be able to manage the respiratory distress, the shock, convulsions, or the trauma. Even if the patient needs to be transferred to the higher center, they should be stabilized before the transfer and not follow the soon and run policy. So you should not scoop and run with the emergencies. You should always stabilize the emergencies and transfer it to the particular center by taking all the precautions which are needed during the transport. Next slide, please. So when it comes to secondary healthcare facility, government or private hospital provides a higher level care with right equipment and manpower. So a primary healthcare facility should identify the problem, should stabilize the problem, and should refer the child to the secondary healthcare facility as and when required. Next slide, please. Primary and secondary healthcare facility cater more than 90% of the rural and urban areas where the module will be very helpful. So as the module will run throughout the country, I'm very sure that all these healthcare facilities will be able to learn. The most important thing is that what the problem the child is suffering from and the stabilization of that problem at the earliest and helping us to prevent the life-threatening conditions going into forward. Next, please. So what does ALS course do? It is non-synonymous with the critical care medicine. It is an advanced life support. It trains us to identify a sick child. It helps us to train to use uniform terminology and trains us to use simple skills to stabilize the sick child. And it also helps us to prioritize steps of intervention logically. So these are the things which are important. It also helps us to train and develop the leadership qualities and effective skills. So you train yourself, then you train your nursing staff, you train your resident medical officers, and the cycle continues. It trains in handling with a difficult situation like a death of a patient. So we'll come to it, that how we should cope with a dying child. How should we counsel the death? We'll come to it at the end of our session. Next, please. So why virtual module? Now, regular courses are not possible now because of the distance problem, the COVID era, and universal precautions of infection control. So we thought of taking it to alternative level and create an e-learning platform to spread awareness of advanced life support protocols. Initially, we all are aware that this was called as a pediatric advanced life support. Then IAP has individualized it and made it advanced life support. And this mass awareness program is just to spread the awareness of advanced life support protocols. The 2-day program which we conduct through pediatric support cannot be taken over. It is the most important 2-day program. Here on virtual program, the session will be 4 hours, and the aim is to use our own skills applied in a systematic manner with the help of checklists that can be shared on this e-platform. But limitation of e-platform is that resources are limited. People can't join due to various reasons, the internet problems, the lack of interest in particular subjects. So this will help us. I thank Central IIP for making this as a presidential action plan and help people to prepare and help others to get aware about the advanced life support. Next, please. So how the model is useful in smaller setups. Decompensated patients are difficult to manage even in tertiary center. We all know that. If the child is coming to you with respiratory failure or decompensated or a hypotensive shock, it is very difficult to manage in the best of the best setups also. There are high chances of morbidity, the cost of the treatment goes high, and eventually the patient dies. So to prevent all this, to prevent the decompensation, it is very important that you all should pick up the problems early. So using simple logic and principles of advanced life support, a diagnosis of physiological derangement can be made early. If you pick up the child early, then you can manage it early and prevent the further complications and the deteriorations and decompensation of the patient. So a systematic approach can reverse them at first contact to the healthcare facility. Earlier, the restoration of normal physiology, better is the outcome. So once you know that this child is having a respiratory distress, you can treat it immediately, prevent it to going in forward for a respiratory insufficiency or respiratory failure leading to cardiorespiratory failure, which is a terminal event. So it is better that you pick up the problem early and intervene early. So that is the beauty of this module, that in spite of any etiology, we are able to classify the problem as either respiratory or circulatory, either respiratory insufficiency or respiratory distress, respiratory failure, or shock as a compensated shock or a hypotensive shock. So these are the things which are very important. Next slide, please. So how the model is useful in smaller setups. Restoration of normal physiology buys time for proper management. Reversal of deranged physiology prevents death. We all discussed this. The ultimate aim of ALS is to prevent death. So some equipment, like simple equipments like pulse oximetry, glucometer, cardiac monitor are handy and useful, and they are now needed in all setups. Even if the peripheral healthcare center, or maybe at the extreme periphery of Maharashtra or any other region in India, a pulse oximetry is must, a glucometer is must, and a simple cardiac monitor is must, because hence you will be able to diagnose the problem the child is suffering from and prevent further deterioration and further deterioration of the baby's physiology. Next, please. So now who can attend this module? So we all discussed all this, but this is very important that any healthcare professional who attends a sick children has to attend this module. And it is a very good module for all of us, not only for the residents, but also paramedics, maybe all healthcare professionals who attend the sick children. So ALS, BLS courses are skill-based courses, but this particular course, the current module, is an attempt to start a system which is going to be helpful in all the times to come. Next, please. Once the COVID is under control and this is possible to conduct actual workshops, the regular courses will start to improve our skills like BLS and the ALS. So now We don't know when the COVID will get over and when we are able to make offline courses and the 2-day courses where there will be no physical distancing. In that scenario, till that scenario, this module will run, and it is a standing invitation to attend all the regular providers for this course and make this happen all over the India. Next, please. It improves our skills and gain confidence in treating the patients. Next, please. And ultimate goal is it saves life. So progression, we'll discuss how the module will progress. Next, please. So important is how to make an impression without touching a patient. Look at your checklist and manage as directed. So the checklist is very important. How to assess a child will be first lecture, and Dr. Akash Bang will take this lecture. Put these principles in day-to-day practice that we'll discuss. Next, please. Modifications in COVID era. How resuscitation changes in COVID area is very important. What are the precautions a healthcare provider should take while treating a patient, because all are suspected COVIDs, all these patients are to be treated as potential COVID victims. And in that case, how to modify our strategy, that also is covered in this particular module. And it gives us a sensitization about how should we cope with a dying child, coping with the death. That is our ultimate lecture on that. So what are the precautions in the COVID time that we also will discuss? In COVID times, all of us are aware that about appropriate precautions that to be taken in your workplace, including use of appropriate PPE. Please approach patients with proper precautions all the times, because once you are safe, then everything is safe. So stay safe and take all precautions, including donning appropriate PPE such as gloves, N95 masks, face shields, and etc. Please follow your local government guidelines, ICMR guidelines, and institutional guidelines. So few of the house rules for today's session. All participants should mute their devices at all the time. Questions may be asked in question and answer box that will be taken at the last. Faculty will be answering this question continuously in the box. All participants should be following the proceedings on the screen with a copy of the checklist. So you all have received a checklist. You should take at least 5 to 10 printouts of that checklist and all try to assess when we are discussing the cases. The certification will be awarded from Central IIP, and the criteria for certification is submission of both pre-test, post-test, and the feedback form within stipulated time. So tips for today is keep your printed copies of checklist ready with you. Make your own assessment of all the cases as they are presented here today. Match your responses with those of the instructors. Start using the checklist in your clinical practice today itself. Initially, you may find it time consuming, but I will assure you that it doesn't take too much of additional time to make a systematic evaluation after about 5 to 10 cases. And we'll discuss the case simulations. You all will be able to know at the end of our module that it is very easy if you keep that checklist and you practice through that checklist, that how it is very easy to practice it and implement it in your private practice. You can provide your feedbacks at admin@iapals.org. Thank you. So this is the schedule, and after the brief introduction of the course, I hand it over to Dr. Akash Bang for initial impression and the pediatric assessment triangle. Dr. Akash.
Thank you so much, Dr. Mandar, and good afternoon, everyone. Now, all of you will agree that the most basic purpose of medical profession, of any healthcare professional, is basically saving lives and saving intact lives. Now, when we talk of saving lives, our interventions need to be very specific, very accurate, and quick. Now, for the intervention to be quick and perfect, we need a perfect identification system where we quickly and accurately identify the problem with a child. And coming back, for a quick and rapid identification, we need an assessment technique, an evaluation technique, which is rapid and accurate. Now, I can imagine people thinking in their minds that it takes 2 years of DCH or 3 years of MD and DNB to master this. How can anyone teach or learn this assessment in 15 minutes? So in next 15 minutes, I'm going to cover this. And the answer to this question is, next please. We are going to do this. We are going to do a systematic assessment with the help of this beautiful tool called IIP ALS tool. Now, let's understand why it's called ALS tool. What is BLS? BLS basically, next please, keep on clicking. So BLS is required for a victim of cardiac arrest, right? And what is ALS? ALS or advanced life support is required before the cardiac arrest sets in. So this is the science which helps you to prevent death. Okay. Now, how can a simple 3-page tool, I'm sure many of you must have seen this tool or must have downloaded this tool. So how can a simple 3-page tool help us do this mammoth task of systematic assessment and identification and doing some intervention to prevent death? So the answer lies in the concept of what is called as final common pathway. The concept is that you imagine any pediatric illness, any illness, okay? May it be pneumonia, may it be severe diarrhea with dehydration with shock, or may it be a road traffic accident, malignancy, anything for that matter, okay? The final pathway to the death is common. So, and that entails either respiratory failure or circulatory failure in terms of shock, or sudden cardiac failure in terms of arrhythmia or cardiac arrest, sudden cardiac arrest. So because this common pathway to death is, the pathway to death is common, if you focus the tool or if you focus your identification system or evaluation system on this final common pathway, what happens is, if you take care of these physiological derangements instead of going into etiological diagnosis, you are able to prevent death. You are able to take care of this physiological derangement, and that buys you time for going into, for ordering investigations or for going into etiological diagnosis. So this ILS tool is basically a series of steps systematically arranged for identification of critical illness with prioritized interventions to postpone death till some definitive treatment reverses is instituted and helps in reversing the disease process. Next, please. Now, this series of steps is compiled in a simple to use tool. This is called IIP-ALS tool and checklist. As we will go through the various cases today, we will realize that this is a very, very simple tool. You can learn this in next 15 minutes and you can practice it in next 4 hours today. And you will realize that not only doctors, but nurses, paramedic workers can also be trained in using this IIP-ALS tool. The unique feature of this tool is that in addition to guidelines about how to assess and how to identify problems, it also provides intervention steps. Okay. So when we talk of IIP-ALS tool or any assessment, the first thing is called as initial assessment. Now, what is initial assessment? Let me give you a simple example. Think of a Monday OPD. Now, this is obviously before the COVID lockdown started because nobody is wearing masks here. So think of a busy Monday OPD when you walk into your clinic and you come across this 1-year-old, next please, 1-year-old child who came with cough and cold since 3 days and he's waiting for his turn in OPD. Next, please. You are also told about this 6-year-old child who was brought with history of one episode of seizures at home. But when the child reached pediatric emergency room, this is the status of this child. Okay. Next, please. Look at this child. So the audio was not audible. Just go back, please. Go back, please. So the audio was not audible. So I think for next cases, I request the central IIP IT support system to check into the sound issue. Probably the sound will need to be increased. So just go back, please. So this is the child that was shown here. This is a 7-month-old child who presented with fever, cough, and fast breathing for 4 days. And for last 2 days, this child is having abnormal inspiratory sound, which cannot be heard now, but it was a stridor sound. Okay. Now, between these 3 cases, we saw 3 cases till now. Okay, the first child was sitting in OPD with URI. Second child had seizures, but when he was brought to pediatric emergency, you saw the status. And this is the third child. Between these 3 cases, whom would you want to see first in your OPD? I'm sure your answer would be the third child, because there is stridor and the child is definitely quite irritable. Next, please. Now, as you are seeing the third child, suddenly a fourth child is brought into your chamber by an anxious and worried mother. So you can see this child is drowsy, lethargic. Go to the fifth case. Next, please. And while you are examining the fourth child, suddenly this fifth child is brought to you. This child has been rescued from a bathtub at home. He is unresponsive and not breathing. Okay. So I want all of you to think in your mind which child would be taken first and what would you do with each child. Okay. Next, please. So based on the initial assessment, I'm sure each one would agree with me. The case 1 would just probably wait for their turn to come because this is a stable child. Case 2 was a post seizure child, but looked okay at this time. So you might want to wait and observe this child. Case 3, definitely there was a stridor and the child was irritable. You would attend this child urgently. You would nebulize this child with adrenaline and provide oxygen. So this child needs urgent attention. Case 4 also needed urgent attention. You would probably start oxygen. You would probably start IV fluid, get an IV access for this child. Case 5 definitely needed immediate attention. The child was unresponsive and not breathing. So this child would require cardiopulmonary resuscitation or CPR. Now my question is, next please. My question is, did you notice that you did not require any history or any detailed physical examination to take these decisions? Okay. So yet appropriately we have managed and probably saved a life if we start these interventions that we just enumerated. So this is the beauty of initial assessment. So just think, what exactly did you look at? When you looked at these children, what was it that you looked at? We'll try to demystify this initial assessment. Next, please. So initial assessment. Am I audible? Can someone just show me a thumbs up? Am I audible?
Yes, you are audible.
Okay. Thank you. Yeah. So the initial assessment basically consists of something called as pediatrics assessment triangle or PAT triangle. There are 3 components of this pediatric assessment triangle or initial assessment. These include ABC or CBC. So appearance, A for appearance or C for consciousness. So that is the first component. Second component is B for work of breathing. Third component is C for circulation. Next, please. So appearance or consciousness basically reflects upon the neurological status. Next, in breathing, we are just getting some primary information about the respiratory pattern or respiratory status. C. Next, please. C means color, which is going to provide us information about the circulatory status. The beauty of this assessment is, next, please. Beauty of this assessment is, if you have noticed, we did not take more than 10 to 15 seconds to perform this. Within 10 seconds, we immediately prioritize. We had 5 cases, and just based on our 5 to 10 to 15 seconds, hardly 10 seconds of assessment, we decided which one needed immediate CPR. We decided which one needed acute care. We decided which one can wait. Okay. So what did we do? We just based our assessment on some visual and some auditory clues. Okay. We did not require any equipment for this. No pulse oximeter, nothing. Just our eyes and our ears and just 10 seconds of time. Next, please. So let me go into slightly details of this initial assessment. So when you are looking at consciousness, what you are looking at is how the child is behaving and what are the options, what are the possibilities that you might encounter. Next, please. A child may be alert. Next, please. So a child may be alert, in which case you may just proceed with your evaluation. A child may be agitated, irritable, or lethargic. In any of these cases, this is classified as yellow, and that this child needs some acute care. So probably you would start oxygen, you would attach monitors, you would take blood sugar, because this child could be hypoglycemic and that is why he is lethargic. Third possibility is a child may be completely unresponsive, and that is the time when you call for help and start the BLS algorithm. Okay. Next thing is breathing. You are just looking at breathing. You are not even counting respiratory rate here. So when you just look for breathing, breathing can be normal, or it can be fast or labored, or it can be slow. If it is fast or slow, this child would probably need oxygen. So you would ensure oxygen. Third possibility is that a child may not be breathing at all, or maybe just gasping. If the child is gasping or not breathing at all, this child needs assisted ventilation in form of bag and mask ventilation. In addition, if you also find that the perfusion is poor and the heart rate in primary assessment is found to be less than 60, then the child will also need chest compression. Right? Next, please. Next, you assess color. Next, please. So color can be pink, in which case you can oxygenation for this child. You would also go for IV access to. Next, please. So we immediately decide based on our assessment of CBC whether this child goes into red zone, which means that CPR is needed. So our actions would be, we would start CPR and we would proceed with IIP or IIP BLS algorithm. Or whether this child goes into yellow zone or green zone. Yellow zone means some acute care is needed. CPR is not needed here, but some acute care is needed. In this case, you would quickly gather your team and assign jobs to arrange. Number one, monitors will be attached, oxygen will be started. You would also go for point of care RBS, blood sugar. You would go for IV cannulation, and then you will proceed with your detailed assessment of primary assessment, that is ABCD. If the child falls in none of the above, then you don't need to do any intervention at this moment of time, and you will go ahead and proceed with your further evaluation. Next, please. So again, I would like to reiterate to remember that it just takes about 10 seconds to identify a life-threatening serious condition and initiate. And that is the beauty of initial assessment. That is the objective of initial assessment, to make triage, pick up life-threatening situations and manage them on priority basis. And the assessment is so simple that even your reception staff or any paramedic worker can identify if you train them. Next, please. So that finishes our initial assessment. If there are any questions, as already instructed, we would like you to keep on posting your questions on in the question and answer box, and the faculty will keep on answering them as and when. Some unanswered questions can also be taken at the end. So thank you. Next, I call upon Dr. Meenakshi Girish to discuss the next part of the assessment, that is primary assessment.
So welcome everybody, and thank you Akash for that nice initiation into pediatric ALS e-module. Akash has finished at the point where you have just looked at the child and you have made an initial assessment on and decided on initial intervention. So by now you have decided whether this child by look is stable or unstable, And if it is unstable, you have decided whether this child requires immediate CPR or whether this child requires urgent care. So after your initial assessment, you have done this, and you also have already decided that if it requires urgent care, you have done 5 things. What are those 5 things you've already done? You've called a team of people, if available, to help you manage this child. Second, you have asked somebody to put monitors on the child, maybe a pulse oximeter if available. Third, you have asked somebody to do a blood sugar immediately. Fourth, you have asked somebody to start IV cannula. And fifth, most important and the easiest intervention and the most life-saving intervention, you have asked somebody to start oxygen. So you have done 5 things already. While all these 5 things are happening within seconds of you looking at the child, you move on to the next part of assessment, which is primary assessment. In just like initial assessment you remembered as ABC or CBC, primary assessment, the structure of assessment you remember as ABCDE, of which I am going to talk about. Can I have the previous slide still, please? Of which I am going to talk about the A and B part. The remaining C, D, E will be covered later. So before I start with the primary assessment, the A and B part, Nivedita, can I have the next slide? Let me ask you a very interesting question. Next. How long do you think one can live without food? So I'm sure the answer would be you can live for months together, months at least without food, or weeks. Next. How long can you live without water? Well, a few days at least you can live without water. Next. But how long can you live without air? And the answer should be instantly 6 seconds. Next. So you see, oxygen is more vital to our body than food and water. Any impairment in delivery of oxygen will be a threat to life. And that is why you have to learn ALS so that within the window period of 6 seconds, you are able to restore oxygen to a child who is in trouble. So another peculiar situation about pediatric ALS I would like to tell you. Next slide. You must understand that in pediatrics, the commonest reason why oxygen deprivation will occur would be because of respiratory problems, unlike adults who collapse because of lack of oxygen because of cardiac causes, sudden cardiac causes. In pediatrics, you find respiratory problems causing oxygen deficiency more often. And that is why we have to give importance to airway breathing, of course, along with circulation. But airway breathing becomes more important cause to identify and intervene in pediatric age group. So in the next 10-15 minutes, what I'm going to take you through is how to identify respiratory problems very quickly within that window period of 6 seconds to restore oxygenation. So next slide. Can I have the next slide, please? Now, we all are very familiar with this information that oxygen enters our body from air. First, it goes through airways and then it enters the lungs, where the lungs have to be healthy enough to take in oxygen and give it over to the blood vessels. And then the blood carries it to the rest of the body. So when it comes to identifying oxygen deficiency because of airway or breathing problem, the first thing we have to make sure that the airway is patent to allow oxygen to go to the lungs. And then we concentrate on the lungs to see whether there is a problem in the lungs causing the child's critical condition. So this is the oxygen pathway we're going to talk about first. So first we are going to talk about airway. Next slide. Fortunately, we don't need a bronchoscope to identify airway problems causing obstruction to pathway of oxygen. All you need to do is to listen carefully, because all airway related problems will produce an abnormal sound in the breathing. And identifying the characteristics of this sound will not only help you to identify that the problem is in the airway, but it will also tell you at what point level of the airway the problem is, so that you can choose the appropriate intervention. So let's take you through how you identify airway obstruction to oxygen passage by identifying the sound. Can I have the next slide? Okay, I'm sure none of you would have heard any sound. Previous slide, can I have a previous slide?
Okay. Can they improve the sound?
No, sir, I think improvise here, there's some problem with the sound. But since you listen to this video, I can tell you that even if the sound system was working, what you can see is the child is having a problem. By initial impression, you know that this is a child who requires urgent attention. But if you use your ears and if this video audio was working, you would have heard no abnormal sound. So this is a child who's 2-year-old who is apparently sick. But my voice is echoing. Nivedita, you'll have to mute your second system. You're logged in by 2 systems. Can you mute it? Yeah. Can everybody hear me?
Yes.
So in this child, there was no abnormal sound to hear other than the breathing. So we know that this child has a problem, needs urgent care, but the problem is not in the airway. Now let's go to the next slide. This is a bit of a problem. I wish all of you could have heard this sound from this video, but since it's not there, let me tell you that this child had a sound which would resemble somebody snoring. Okay. And it would be, is it audible to you, Nivedita, the sound?
No, I can hear it. I can hear in my device.
Can everybody else hear?
No, we can't hear, Meenakshi.
Okay. Okay. All right. So let me just verbalize it. This child is sleeping, and this child, when you hear this child's breathing, you'll hear a sound which resembles a somebody snoring. So let me tell you, a sound which resembles a snoring is also an obstruction, but the obstruction is at the level of the nose. Okay. And this kind of obstruction usually doesn't lead to any problem with passage of oxygen. So this child that is why not looking like a very sick child. It looks like a child who's sleeping very comfortably. Can I have the next slide?
Excuse me, Nivedita, madam, you unmute yourself. You are playing the slide. Kindly unmute yourself so that we can hear the sound.
And Mustafa,
Okay. Is it audible now? Is it audible now?
Yeah. Mustafa, kindly check the sounds in the video.
Sounds are with the Nivedita Patil madam only from Central IIP. It's not with us.
Check again.
They have the controls. We don't have it.
AIP ला कंट्रोल आहे की आपल्याकडे आहे यश कडे
नाही CIP यांच्याकडे स्लाइड्स आहेत ना निवेदिता मॅडम कडे.
All right, just let me continue. I think I can make it as easy as possible without the sounds. So pardon us for this technical failure. This is another limitation of e-module that I'm sure the first speaker would add in the slide. No, but anyway, in this sound, what all of us are pediatricians, all of us are either post PG or doing PG, you would know that this child, if you hear this child, she would have a sound which is abnormal, but which is heard predominantly during inspiration. In this child, the sounds would occur in inspiration as well as expiration. But even though the sound would, abnormal sound would be in expiration, what is important to understand is the sound is there during inspiration. Any abnormal sound in inspiration straight away leads to a diagnosis of airway problem. Not only airway problem, it also tells you that the airway obstruction is in the part of the airway which is outside the thorax, that is in the trachea. So just by listening to an abnormal sound in the inspiratory phase of respiration, you can immediately decide this child is having trouble because there is obstruction in the extrathoracic airway. Next slide. And all right. So in this patient, you can see by initial impression that this child is awake and alert. But if you see observation, there is some respiratory problem. And you can right away by listening, you can identify where is the problem. The problem is again in the airway, because if you were able to hear the crying of this child, the very classical audible wheeze. And we all know that the wheeze is always expiratory. Now, any abnormal sound which is heard in the expiratory phase of the child's breathing means this airway problem is in the intrathoracic, in the airway which is within the thorax. So it is an intrathoracic airway problem. Can I have the next slide? So just by listening to the sounds, without using your stethoscope, without using any kind of sophisticated bronchoscope, you have been able to identify the location of obstruction. Okay, and you have been able to identify whether the obstruction is in the airway first, and second, whether in the airway, whether it is in the extrathoracic airway or the intrathoracic airway. This location identification is important because your intervention will depend on at what anatomical part of the airway you identify the obstruction. So when it comes to interventions, can I have the next slide, please? What kind of intervention will you plan? Now remember, we have diagnosed it as an airway obstruction, and your immediate task is to open the airway to relieve the child. Now remember, if the child is conscious like the last patient, then the child, a conscious child, will automatically assume a position which will partially at least relieve the airway obstruction. Previous slide. Don't go to the next clip, please. So when the child is conscious, do not do anything to, do not try to position the child to relieve the airway obstruction, because the child will get agitated and it will lead to further obstruction. But if a child is unconscious or drowsy and you diagnose airway obstruction, then there are certain maneuvers that you can perform to relieve the obstruction. That is, one is positioning the child to keep the neck open, which you would have learned in BLS. Second is you can try suctioning. Third is you use some simple airway adjuncts to keep the airway open and relieve obstruction. Or you can use drugs. Now, the two drugs which are very useful to relieve airway obstruction are nebulization with salbutamol and steroids. Remember, we are talking about partial airway obstruction. A child with complete airway obstruction would not be able to breathe at all. And this is a complete emergency requiring CPR, which would have been initiated at the point of initial assessment itself. Next. Now, all these airways where the obstruction is relieved by these maneuvers are called as maintainable airways. Obstructed but maintainable airway. When these maneuvers do not still relieve the child, we call it as unmaintainable airway. And usually you see such kind of airways when there is a accident or an injury, and these airways finally require a placement of endotracheal tube to relieve the obstruction. Next slide. Now these, you see on this slide, these two and this third, these three objects are used for relieving obstruction. That is suction. And remember, when you use suction and you put the suction catheter in the airway to suck, remember the suction procedure should not last for more than 10 seconds at any point of time. Oral airways and nasopharyngeal airways are two airway adjuncts which are used when you see a child is having airway obstruction, particularly of the extrathoracic airway type. Now, oral airways are not to be used if the patient is conscious. It is to be used only if the patient is unconscious. But nasopharyngeal airway can be used even in a conscious patient. But remember, it cannot be used if the patient is a case of head injury, because there might be injury to the cribriform plate at the back of the neck, nose. Now, these three equipments are for giving oxygen as a intervention maneuver for obstructed airway. Nasal cannula, high flow oxygen, and oxygen hood. And this is as a last resort in an unmaintainable airway. When you're not even skilled to intubate a patient, you use a laryngeal mask airway. So these are the oxygen adjuncts and oxygen delivery devices to relieve oxygen deficiency because of airway obstruction. Can I have the next slide? So to summarize, just airway problems leading to oxygen delivery. Next. Broadly speaking, the problems with airway could be that there is a nasal block, or there are secretions in the airway which you can actually see visibly, or you can hear a stridor, which is an inspiratory sound, or you can hear a wheeze, which is an expiratory sound, or you know that the airway is obstructed because of a lot of blood or secretions or some kind of injury to the airway. These are the problems that you are supposed to identify just by listening to the patient. Next. And then you diagnose the problem with the airway as either it is a clear airway or a maintainable airway, or it is a unmaintainable. This is what you're supposed to tell yourself when you evaluate a critically ill child, whether the airway is clear, maintainable. If maintainable, what interventions to use? You can use nasal drops, or you can do suction, or you can use drugs like salbutamol or steroids. You can position the patient or use airway adjuncts. If the airway still doesn't open with all these interventions, or it is a case of injury, accident, then you declare that this is an unmaintainable airway and you put in an endotracheal tube. Next slide. Let's go on to, so basically it took me a few minutes to tell you all this, but when you actually perform this, you will realize that it hardly takes a few seconds to make sure that the airway is open to allow oxygen to go into the lungs. Can I have the next slide? Now we move on to assessment of breathing. You've just done airway. Now look at this child. Now, when you assess breathing, you need very few equipments and you need a good pair of eyes. Now just look at this child and tell me whether the breathing is normal or not. Obviously, you're looking at some things to decide whether the breathing is normal or not. Next slide. What are the things you look at? I don't think this video will play. Can you play this video? It wasn't playing in my...
No, this video cannot.
So we move on to the next slide. So when you look at a child's breathing, there are 5 things you have to assess just by looking and by using minimal equipment. The first thing you assess is by looking, and that is to decide whether the breathing is fast, slow, or there is absent breathing. Next. This is easy. Anybody can assess. Next. If the breathing is fast, remember it is either because the child is getting less oxygen, even though the airway is open. So there is something wrong with the lungs which is not able to collect the oxygen which is coming towards it. Or next, it could be because the child requires more oxygen than normal. Either way, if the breathing is fast, it means that the child requires oxygen. Next, if the breathing is slow, then the problem is not particularly in the lungs. Next, it could be because the problem is in the brain. Next, or it is some kind of poisons lead to again brain dysfunction and slow breathing. Next, or it could be a cardiopulmonary failure. So if the breathing is slow, still the oxygen will be required, but the oxygen has to be given by a positive pressure ventilatory device. Unlike when the breathing is fast, you don't need a device to give oxygen. You need those oxygen delivery devices that we routinely use. So this much you understand just by looking at the patient and looking to see whether the breathing is fast, slow, or absent. Next slide. Remember, we are not dealing with a child at this point who is not breathing. This should have been dealt with in the initial assessment itself. Next. Now, when you look at a child, you not only just look at the child, whether the child is breathing fast, slow, or absent, you also want to know whether that particular breathing is adequately providing oxygen to the rest of the body. Now, how do you assess adequacy of breathing? I told you there are 5 things you look for under B, that is breathing. What are those 5 things? First, one is rate. Can I have the slide? Can I have the slide, please? First is you look at the rate. Next, you look at the effort of breathing. Third, you look at the chest wall expansion. Fourth, you look at now you use a stethoscope to look for, to hear for abnormal sounds within the lungs. Next, and you look for SpO2. So 5 things: rate, effort, chest wall expansion and symmetry, auscultatory sounds, and SpO2. These are the 5 things you look for when you assess breathing. Next. Now look at this video and assess those 5 things. This is an 18-month-old who had fever, cough. And if you see his breathing, it's a fast breathing. Okay. So that is the rate. Effort. Can you see effort? The child is using intercostal muscles and probably the child is using suprasternal retraction also to breathe. That is the effort. Now you look at the chest expansion. You see that both the sides are expanding well. So there's no problem with chest expansion. And then if you look at then you have to do 2 things. You have to auscultate. When you auscultate, you should hear either crepitations or ronca, anything to indicate to you that there is a problem in the lungs. And if you look at the SpO2, if it is less than 95, these are the things which tell you that there is a problem in breathing. Next. So we've just finished assessing breathing. Let's quickly summarize. So I told you these are the 5 parameters. When you look at the rate, can I have the next click? When you look at the rate, you decide whether the rate is fast, slow, or normal. Next click. And the intervention for any type of abnormal rate is either giving oxygenation, which will be with oxygen delivery device or with positive pressure ventilatory device. Next, then you look at the effort. And if the effort is decreased, you would have done something in the initial assessment itself. But if the effort is increased, then you have to again start oxygenation. Next, look at the chest wall expansion. And if the expansion is normal, you're okay. Here you should concentrate more on symmetry. And if the chest wall expansion is not adequate, you might have to start positive pressure ventilation. Next. You oscillate now. And as I told you, you hear any abnormal breathing other than the normal breath sounds, you know, this only confirms that the problem is with the lungs. Next. So you ensure oxygenation. If there is no breathing, asymmetric air entry, breath sounds, then you have to perform a special maneuver. You may have to do a thoracotomy. Next. And based on saturation, it is not 95%, it is actually 94%. If it is less than 94%, what do? You give oxygen. And if it is less than 90%, despite giving oxygen, you start positive pressure ventilation. So this is how you assess A and you assess B. And to recapitulate, to assess A, all you have to do is listen for sounds and try to characterize the sound. To assess B, you have to look for 5 things when you're focusing. You need a stethoscope and you need a pulse oximeter. Okay. Finally, next slide. Yeah. Next. Next slide. So just a word about can we stop there? Just a word about differentiating respiratory distress and respiratory failure. Remember, if the breath sounds or if the breathing is very slow or absent, it is obviously respiratory failure. But many times the breathing may be fast and still the child may be in failure. So when the breathing is fast, you have to differentiate between distress and failure because your interventions are going to be very different. So to differentiate, what are the points? Now can I have all the clicks? So a distressed child will be irritable, not drowsy. He will not be unresponsible. He will be irritable. A distressed child will have tachypnea. A failure child may also have tachypnea with severe retractions, or he may have slow breathing. A distressed child can have decreased air entry and low saturation. A child with failure will also have decreased air entry and slow saturation. But the most important point to distinguish distress from failure is the responsiveness. A child in respiratory failure will not be irritable. It will be unresponsive. So this will tell you what to do. So if a child is next, click. Next. Yeah, the color cyanosis would develop for respiratory failure, but do not wait for cyanosis to diagnose respiratory failure. It will be too late. So if it is a child with distress, all you have to do is give oxygen. But if it is a child with failure, this is where you have to arrange positive pressure ventilation or assisted ventilation. So remember, it took me 20 minutes to tell you all this, but in practice, if you keep practicing this structured approach to A and B, you would see that you don't take more than 2 minutes to start intervention. With this, I would like to thank you all for your patient hearing, and I would request Dr. Mandar Doshi to take over. Sorry, Manish Doshi. Mandar Deshpande.
Thank you, madam. Thank you very much.
I'm so sorry.
Not at all. You're welcome. So, good afternoon, friends. And now we are going on to the next part of our assessment, that is the C of the circulation. Just to, if you hold on the video, please. So, just to again reassess that we are going slowly because we want you to understand each and every point, each and every component properly. But you will be doing this in a manner. So you have to keep in mind that you're going to assess from initial impression, primary assessment, secondary assessment, and all. So it has to come in a flow. Now, having done the B part, we are still on our primary assessment, and in our primary assessment, we are going to now do the C part, the circulation part. Okay, so now we will start with some of the videos, and please have a look at them. This is a child who has come with a history of loose motions and vomiting, and here, if you look, the child is appearing a little pale. This video is just to show that the child is looking a little pale. Next video, please. Here you see a child who's breathing fast, and we would like to draw your focus to the fact that the child is appearing with cyanosed. Next, please. Again, this is a child who's breathing fast, and you would have heard a grunt over here with a good audio. The child is appearing pale and a bit cyanosed. Next, please. This is a child who's breathing at a slow rate. Okay, almost unresponsive. Next, please. So how do we, before we go on to how we assess the circulation, let us first revisit some of our basics or some of our core issues. Next, please. So you know that tachypnea is not only seen in respiratory problems, but tachypnea will also be seen in problems secondary to a circulatory insufficiency. Okay, here we'll concentrate on tachypnea. When we see tachypnea over here, we are going to know that it is because of a circulatory problem. Next. So when there is a circulatory insufficiency, the first thing that happens physiologically as a compensated mechanism is tachycardia and tachypnea. Next. Then you get vasoconstriction to keep up the blood pressure and the peripheral circulation. Next. The peripheral pulses will become narrow, and over a period of time, they will become feeble and disappear as there is more and more vasoconstriction, as there is more and more increase in the peripheral vascular resistance. And centrally, pulses will follow them afterwards. Next. This happens because the body is trying to the body is trying to save the circulation of blood to go to the vital organs like the brain and the kidneys. Following this, the next step will be a delay in the capillary refill time, and the skin will become pale, mottle in color, and lose warmth. So these are all important points because these are exactly the points that we are going to assess in our components of C, that is circulation. Next, please. So this compensating mechanism of the body will support your circulation to some extent. Beyond which, if the abnormality persists and if the disease persists, this compensated mechanism is going to fail and you're going to get an uncompensated phase. Next, please. What is the role of blood pressure in the management of circulatory insufficiency? Now, for the purpose of teaching just now, we are going to say that all circulatory insufficiency means we are talking about shock. Okay, so the question is blood pressure necessary to diagnose shock? The answer is no. Shock is diagnosed not by blood pressure, but by the by other components where you So it is not necessary to diagnose shock, but it is a very vital and important point, important criteria to diagnose the severity of the shock. Next, please. Next, please. So when till the compensatory mechanisms are present and they are active, your blood pressure will remain in the normal range. For our purpose, we consider a normal range of blood pressure is 5th percentile. If the blood pressure is above the 5th percentile, we call it a normal pressure. If it is falling below the 5th percentile, we call it a hypotensive situation, and we call it a hypertensive shock. And this is for the 5th percentile for the age. Next, please. So our whole job and our whole focus should be to identify, to manage a patient with shock in the normal BP range. We don't want a child to fall below the normal BP range. Okay, because when you have a patient who's in normotensive shock or with a normal BP range, we have got plenty of time to manage the patient and his physiology and bring him to normal. Once the patient falls into the hypertensive side, then it can progress to a cardiorespiratory arrest very fast and we do not get enough time. Next. So for that, what is the normal, when is the short form, in short, how do we decide fast what is the normal for that age? So below 1 month of age, from newborn to below 1 month up to 1 month of age, the minimum blood pressure is 60 millimeters. From 1 month, next please. Madam, give me all of them. So from 1 month onwards to 1 year, it should be 70. From 1 year to 10 years, it should be 70 plus age in 2, and beyond 10 years, at least 90. So any blood pressure, and remember, this is the 5th percentile. Also remember that if you have taken a blood pressure reading at first contact, any fall in the blood pressure of more than 10 is significant and should alert you to the possibility of the child going into a hypertensive phase. This we already covered. Next, please. Next, please, ma'am. So what are the types of shocks from our point of view? From the PALS point of view or the ALS point of view, we are interested in diagnosing a patient of shock and putting him into 4 categories. We all know the commonest form of shock is hypovolemic shock, which is because of loss of volume, loss of fluids. Second, please. The second commonest that we see is a distributive shock, which is because of a sepsis or an anaphylaxis. Third commonest shock that we see in our practice is a cardiogenic shock, where you have either a congenital cardiac lesion or you have arrhythmia or you have a myocarditis. Or so a cardiogenic variety of shock is basically the cardiac pump is not functioning well. And the last category that we put our patients into in a shock is obstructive shock, where there is a obstruction to the return of blood to the ventricle, to the heart, and the heart is unable to pump out the blood. That is an obstructive shock. So our whole sole interest in assessing the circulation is to put a patient in one of these 4 categories, because depending on that will be the treatment. Okay, for that, apart from the assessment, we also need a good history from the patient's relatives. Next. So how do we treat shock? In short, the first treatment is going to be, of course, managing the airway, oxygenation. Second, IV fluids, which will depend on the type of shock. For example, in a hypovolemic shock, excuse me, this should be a hypovolemic shock. In a hypovolemic shock, you will require more lines, you will require rapid boluses over a short period of time. Whereas a cardiogenic shock, you will require lesser amount of fluids over a longer period of time, along with inotropes. And obstructive shock, you may not be able to revive a patient with just fluids unless you remove the obstruction. And in other types of shocks, the distributive shocks, you will have to manage the infection. You may need inotropes, fluids. You may need to reduce the metabolic demands of the patient by getting the fever under control, pain under control, with assisting ventilation. Next, please. So let us now assess the components of your assessment of the C part. So this is the child who has come with a history of loose motion and vomiting. The child is appearing pale. The child appears to be drowsy. Okay. So now, next slide, please. In our initial impression, we would have found that this child is a sick child. In a primary assessment, in A part, it was appearing that this child's air is open. In respiratory, we found the child is breathing a little fast with a little bit of respiratory distress. Okay. Now come to C. Next, please. So here, what will we assess? We will assess the heart rate. The rate is very important, as is evident, because a normal rate, a fast rate, or a slow rate will tell us different things. So what will be a normal rate for a 2-year-old will not be same for a 6-month-old. So for age appropriate heart rate, we have to know that the child is having a fast heart rate, slow, or a normal heart rate. Second, next, please. Rhythm. So here, always we talk about rate and rhythm together because they come together. So the normal QRS, so in a rhythm, we look at either the rhythm is fast or slow. And if it is fast, then it is narrow or wide complex. All right. The rates, we know that there are certain cutoffs that we know that we should keep in mind. So if a child or any person who's come with a history, who comes with a heart rate of less than 60, we know that this is abnormal in any age group. And if the heart rate is more than 220 in an infant or 180 in a child, we know that this is falling in the range of arrhythmia or a very abnormal heart rate. Below this, we can still get away with calling the heart rate a sinus tachycardia, provided some features of the ECG are maintained. Okay, so the management is going to be according to the heart rate. If the heart rate is low, less than 60, we are going to start compressions. Otherwise, we are going to go ahead. Next, please. So the third component in management in assessing your C is going to be your pulses, both central and peripheral. Here we are going to see the volume of the pulses. Along with this, the fourth component is your capillary filling time. The capillary filling time should be around 2 seconds. If it is less than that, we call it brisk. If it is more, it is prolonged. So these four components that we saw, and the last component and the fifth, the next component are going to be the skin color, the skin temperature, and the blood pressure. So if you see, can I thank you, man. Can I get all the slides? Yeah. So if you see, what we are doing here is we are assessing the cardiac contractility in the first by heart rate, rhythm, your pulses, your CFT, and your blood pressure. We are seeing the cardiac contractility, and with the skin color, skin temperature, and your, this is not showing on the slide, with your sensorium, we are looking at the end organ perfusion. So all these components will become part of your C. The skin color will tell you whether it is, when you assess the skin, either it will be pale, whether there will be cyanosis, or the skin is normal, which will give you an idea as to the circulation. Skin color and temperature will tell you whether if it is cool to touch, the peripheries, are they warm, in a septic shock, they might be warm, or they are normal. Blood pressure, we have already seen that the blood pressure systolic should be at least above 90 in any child who's more than 10 years of age, and appropriate to the age we already seen the found. Next, please. So this is how we went. Whatever the compensator mechanisms were there in a patient who gets circulatory insufficiency, those we are assessed over here with our components of C. So each and every component of C is very important, and we would do well not to miss a single component. Each and every component either brings in or removes a diagnosis of shock. Blood pressure is very important for managing for diagnosing the severity of the shock. All right. Thank you. Next, please. So the next organ which we are going to assess is the brain, and the next assessment in our circulatory assessment tree after C comes D, that is disability, which will assess the brain. And for this, I would like to invite Dr. Manish Jain to take over the proceedings. Welcome.
Yeah, good afternoon, everybody. Thank you, Dr. Manish. And as we all are aware that there are 5 components A, B, C, D, E for the assessment. Till now, what we have seen is ABC. And now what we'll be seeing is the next organ is brain, and which is an important organ to sustain life. Next slide, please. So, when we talk of brain dysfunction, next slide. Yeah. It can be because of various reasons, and some of the primary reasons we see normally are infections, injuries, toxins, malformations. There can be genetic abnormalities or some metabolic abnormalities which may lead to brain dysfunction. When we talk of secondary brain dysfunction, it is mostly because of either hypoxemia or ischemia. And remember that hypoxemia can ensue because of respiratory insufficiency, circulatory insufficiency, and various other environmental reasons. Ischemia can be present because of circulatory insufficiencies, other vascular disorders, and there are many other causes which can cause ischemia. Next slide. So, remember that after having taken care of ABC of the child, the secondary cause have already been addressed. Next slide. Yeah. So, when we talk of survival of brain, there are 2 important segments of brain that are important for survival, and that are cortex and brainstem. So, as we are aware with AVPU scale and GCS scale, these are the 2 scales which can be used to rapidly assess the functioning or the action of the cortex. And I think everybody is aware of AVPU scale and GCS scale, so I will not be going in details of this scale. And as far as the assessment of brainstem is concerned, it is mainly assessed on basis of pupillary response to the light. Next slide, please. So, but remember that when you are looking for the brain dysfunction, always remember to do a sugar at point of care, because it helps to identify life-threatening and potentially reversible metabolic abnormalities that can affect the brain. Next slide. So, now since we have seen the how to assess the brain dysfunction, here is a small case. I request all the participants to have a look. Yeah. So any of the participants would like to comment on this? Dr. Nivedita, just stop the video there. Yeah. Yeah. Any of the participants? The peripheral, the slide shows that the peripheral and central pulses are filled. Blood pressure is 84/50 millimeters mercury. CRP is maintained, and heart rate is around 133. And you can see the way the child is lying. Any comments from any of the participants? Yes, anybody? Okay. Next slide, please.
They may
Seeing
not,
this chart,
Dr. Manish may not be able to comment. They will comment in chat box.
okay. So I don't think there is any comment. So I will try to summarize that slide. So probably the GCS of that baby was low, and we would like to go for elective ventilation with 100% oxygen. But the parameters were suggested to be normal. But in such case, when GCS is low, we would like to have a maintain the circulating volume. And as it seems that the child was having some kind of brain dysfunction, we would like to investigate and treat the causes of brain dysfunction. And if we find that there are signs of raised ICT, then probably we will have to go in for measures like elevation of head to 15 degrees, or pharmacological maneuvers like 3% saline or mannitol, and if need be for craniotome. Next slide. No. Have we missed anything after in the initial examination? Next slide. Yeah. So always remember that till now what we have been talking about A, B, C, and D. These things are very obviously visible to anybody. But at times we don't expose the child properly, and this leads to missing of various important clues like patient may have bleeding or have some kind of rashes or some kind of injuries which you tend to miss if you don't expose the child or if you don't examine the child completely. Next slide. Yeah. So you are likely to miss bleeds, rashes, abdominal distension, fractures or deformities, and important thing to remember is that many times even the person accompanying the child or the caregivers, they are not even aware of the existence of these kinds of things. So always remember, next slide. Yeah. So always remember to expose the child as appropriate, but at the same time, respect privacy and modesty in a comfortable ambient temperature. Next. So this you can see, this is a slide showing abdominal distension with visible peristalsis and could have been missed under the clothes. Next. Yeah. So this finishes with the disability and exposure. And just to have a rapid revision of primary assessment as far as the disability and exposure is concerned, disability again, we judge by GCS or AVPU scale and pupils. The reaction of pupils to the light, that gives us about the level of the disability. Next. Yeah. Next. And as far as exposure is concerned, we basically would like to go in for core temperature, whether the patient is febrile or not. Patient is febrile, we would like to give monitor. We would like to give paracetamol. Along with that, we would like to check for RBS. And as I told you earlier, that we need to expose the child properly to see for presence of various deformities, swellings, injuries, or bleed. Next slide. Yeah. So you can see if you follow the checklist, then it is very easy to do this disability and exposure assessment, and it will not require many time. But remember that you have to follow the checklist. Thank you. Now I invite Dr. Anjali Madam to take the secondary assessment.
Yeah, hello. Good afternoon. Now we have finished our initial assessment and our primary assessment. So what we did in our initial assessment was CBC, and in our primary assessment we went A, B, C, D and E. So now we have, by this we have to correct any life-threatening situation which we come across. After that, now we go to the secondary assessment. Next slide, please. Yeah, now, okay, this was in the, this was respiratory insufficiency, what we identified as a severity in respiratory. Next slide. In the respiratory insufficiency, we should identify either it is a respiratory failure or respiratory distress. Okay, then next slide. Okay, and these four types are identify the type of your respiratory problem: upper airway, lower airway, parenchymal, or disorder of control of breathing. In circulation, the severity is either hypotensive shock or your normotensive shock. And what is your type? Type are all those your hypovolumic shock, obstructive shock, cardiogenic shocks. And according to that, you have to start treatment. And the last, if you can't identify, the child will go in cardiopulmonary failure. Next slide. So now we have next. We have done this. So what to do if you have a normotensive shock and if you have a hypotensive shock? You have to start IV bolus, and that is normal saline bolus. Next. In your distributive shock, again inotropes will come into action, ventilation will come into action, and normal saline boluses will come. Next. In your cardiogenic shock, you have to restrict IV fluids and start him on inotropes. Next. And obstructive shock, you find the reason what is obstructing, and accordingly you have to relieve that obstruction either pharmacologically or mechanically. As we go on to the cases, we will come to know. Next. Now, the history is also important in the pediatric emergency. Next. So you have to categorize the type of shock and the type, those four types of shock. You have to identify the allergies. Look into the pattern of illness which suggests what is the possible etiology, because up till now we are only seeing the physiological derangement. Then you have to go to a specific etiology, and for that etiology now you have to go into your secondary assessment. Next. Next slide. So our objective now is to gather all your relevant information in a very short period of time so as not to compromise on any life-saving interventions. Next. So what do you mean by secondary assessment? Secondary assessment have only two components, that is focused history and focused physical examination. What do I mean by focused history? That means that is a mnemonic which is a sample, which is signs and symptoms. Then allergies. The child can be allergic to food, milk or environment. What medicines he has been taking. Then like anticonvulsant, whatever it is, you have to take a proper history. Then past medical history, like tells you the comorbidity, like asthma, diabetes, whatever. Last meal is very important because you may have to give the child sedation or you may have to do certain procedures. And the events, what has the events had occurred, so the child has landed up in your ER. Next. So now in the secondary, as I told you, two components, focused physical examination and focused history. So in history we finished. Now in focal examination, these are those points which you have not covered it in your primary assessment. So what have you not covered in your primary assessment is your head, eyes, ears, neck, throat. So what do you see in that? Tonsils you see neck stiffness. Then in CVS, you have to rule out any murmur, how are the sounds. In per abdomen, you have to see what are the cardiomegalies, etc. PNS, any signs of your neck stiffness or raised intracranial tension. Then relevant local examination. As Dr. Manish said, that if you have any bruises or anything, you have to find out are those any signs of evidences of infection or evidences of inflammation. Next. So now by doing this, where are we now? We have come to a specific etiology from a physiological derangement. So in summary, we have to see first is your clinical impression, which is CBC or ABC. That is also called as a doorway assessment. You don't have to touch the child. It is a quick auditory and visual assessment. Our seniors are really expert in that. Our HOD, when she comes, she says, no, this child looks very sick child. How does she know? This is through clinical impression. Then the primary assessment is a systematic A, B, C, D, airway, breathing, circulation, and then disability and exposure. You know the severity of physiological derangement, what I have told you, that 2 types in respiratory, 2 types in circulatory, and the types are 4 and 4. Then secondary assessment, which is by your sample history, which is a focused history and a focused examination. Then a lab, and last is your investigations and imaging. So you come to a specific etiology and know the extent of damage. Next slide. I think I finished my secondary assessment. We can go to our integration sessions. Those are our case discussions. Now I call Dr. Manish Jain and Dr.
Dr.
Mandar.
Anjali.
Yeah.
Anjali, just 1 minute. Before we go on to the integration session, we would like to invite and felicitate one very special person, the National Coordinator of ALS, Dr. A.K. Sharma.
Yes, sir.
He has been unable to log in initially for some issues. Dr. A.K. Sharma is here. May I request Dr. Sharma sir to say a few words, sir?
Thank you, Dr. Akash, and thank you, IAP Nagpur, for inviting me here. I was supposed to be here in the beginning as well, but as he mentioned, this because of technical snags, this was not possible. So I hope the key points which we take from here is that number one, we should be ready for this situation. When a single person, the appointed person, is not doing or not available for a certain job, there has to be some alternative. Second thing is that over the last 2 decades, you must have observed that there has been a shift of participants in the ALS courses. Earlier, very senior persons and all the practitioners and all, they used to come. Now, the change is that only residents and the young people, they are coming, and that too sometimes for learning, sometimes for certificate, sometimes for which is required for jobs and other things. So the purpose was we will try to analyze why is this happening. So we thought this is 3 days rigorous course, 1 day for BLS provider, 2 days for ALS provider. So this makes somewhat cumbersome to many. And at the end of the day, the evaluation and then the fear of failure also with the senior person, this doesn't go well. So we thought of bringing out something that people can just they come and learn and go without the fear of being evaluated. So a one day MAP ALS was designed, and as you must have noticed, MAP. This is mass awareness program. So what is mass awareness? We have got 30,000 pediatrician friends at least enrolled in the IAP register. So if we are able to reach them, then I think our purpose is served. So how to reach them? So again, the 1 day course we did last year many times, at least 27 courses they were done. This year, this was not possible because of COVID. So what could we do? We devised this 4-hour short module. Now this can be taken to any corner of India. And I am hopeful that all of us who are here to attend this, they will carry this on to every corner. because the idea is to have a system in place to change our thinking that if the child is having respiratory failure, unless we open the airway, we should not do the bang in mask ventilation. A comes before B, and unless the airway is open, the breathing will not work. So the similar type of messages. If somebody says in Nagpur, I have given 20 ml, I have given a bolus, I know what does this mean. If somebody has said in Calcutta that I gave 100% oxygen or high quality CPR, even a person in Bombay knows that what does this mean. So uniform terminology, uniform actions, and as you must have seen by now, that this is not very difficult. In fact, we practiced in a district hospital in Rajasthan, where we called only these PHC people. They were not in habit of doing CMEs and all, and they were able to do as well as the others are doing in tertiary care. So we are able to percolate this knowledge till PHCs and lower levels. I think our purpose is solved. And I'm sure that Vajon being so active in all the academic activities and particularly in ALS, with Dr. Anand, now the stalwart in this field, all of us should promote his vision, Dr. Anand Shandila, in keeping in mind, we should percolate this message till the grassroots, because ultimately, unless the patient is stabilized at periphery, even the tertiary care centers, they will find him difficult to manage. So with this message, I thank you again very much, and my best wishes for not only this ALS, but the whole of your program. Thank you.
Thank you, sir. Thank you very much. It was a pleasure hearing from you. We were unfortunate in the morning that you couldn't connect. Dr. A.K. Sharma is pioneer of IAP ALS MAP e-module. And thank you very much, sir. Thank you. Now we'll have integration case scenarios. Dr. Nivedita.
So, Dr. Nivedita, are you ready with the sound issue?
Yeah, I'm ready with, we can start.
The sound issue is fixed, no?
Yeah, just give me feedback after the first case, but I have fixed the point.
Sure. Okay, so for the first case, I call upon Dr. Mandar Deshpande and Dr. Manish Jain.
Yeah. Good afternoon once again.
Just one more thing. The session is being streamed live on YouTube. So I am told by the IT support section that if only the speakers keep their videos on and rest everyone put their videos off, that will be helpful. Thank you so much.
Dr. Mandar, and here is a 7-year-old female child who was presented with history of fever, difficulty in swelling and swelling over the neck since last 2 days. And since today morning, the parents are complaining that she is having noisy breathing. So I request you to kindly take over and manage this case.
Thank you, sir. I'm in the emergency room and I'm managing this case. I'll first look at the consciousness of the child. The child looks anxious. The work of breathing is past, and I'm looking at the color. The color is pink. With the work of breathing, there is some inspiratory sound which is coming up, probably stridor. Now, at the end of my initial impression, I'll...
Nivedita, can you help the second slide?
So Nivedita, you can just pause it. The video will play automatically. You will have to pause it.
Yeah, Dr. Mandar, go ahead.
Yes, so here the two limbs of pediatric assessment triangle are involved. They are in yellow zone as per the IAP ALS tool checklist. Now, since two parameters are in yellow zone, this child requires acute care. So I'll gather my team, assign them the responsibilities, 100% oxygen by a non-rebreathing mask at 10 liters per minute. And the meanwhile, I'll do a quick random blood sugar of this child and start with the primary assessment. So with primary assessment, are you able to visualize the slides, sir? I'm not able to see the video as well as the slides. Dr. Nivedi.
Can you see the slide now?
No, I'm
Hello?
not.
Are you able to see the slides?
No, I'm not able to see the slides.
Dr. Manish, you can continue.
Are you able to see the slides?
Yeah,
We are
we
not
can.
able to see the slides.
Because
We are
everyone
able
is
to
able to see the slides.
Okay, it's okay. With the initial impression, my impression is the child requires acute care, and I will move for the further care of the child. I'll look for the primary assessment of the child. I'm looking at the airway, and it is very clear that this child has a low-pitched stridor. So the airway is having a problem. There is inspiratory stridor which is coming out. This though the airway is maintainable, this child requires positioning for the airway as well as suction if required, and I will apply oxygen as well as I will start nebulized steroid or prepare for injectable dexamethasone. In the meanwhile, I shall continue with the assessment of my breathing. She is breathing fast. She is breathing at a rate of 36 per minute. I am looking for the increased work of breathing, the retractions, the suprasternal retractions. Now I am auscultating for the air entry on both the sides, and I can detect that the air entry on both the sides is diminished, and bilaterally it is equal, but it is diminished. I am looking at the saturation. Saturation in the room air was 89%. Now it has picked up to 93% with application of oxygen by non-breathing mask. Now I will initiate the interventions that will be needed for assessment of circulation. I will go for examination of the circulation system. What is the heart rate? The heart rate on the monitor is 130 beats per minute, and the P waves which are visible and QRS complexes which are visible after the P wave. So this child has a sinus tachycardia, but the child has she has a heart rate of 130, which indicates that she has a tachycardia. I'll look for the blood pressure of the child. What's the blood pressure, sir?
Blood pressure is 90 by 60 millimeters of mercury.
Manish, sir, what's the blood pressure?
It's 90 by 60 millimeters mercury. Mandar, am I audible?
Okay.
Mandar, it is 90 by 60.
I'm looking at I'm looking at the capillary fill time, which is 2 seconds, which is normal for the age. I'm looking at the extremity temperature, which is warm. The extremities are warm and the color of the skin is okay. All checks indicate that it is appropriate to have some actions over here. We started on oxygen, we started on nebulized steroids, and we started on dexamethasone. I'm looking now at the D part of my assessment. The child looks anxious, and the child has though drowsy, able to interact and produce respond to voice. So on a scale, she is between 8 to 12 of score of V on AVPU scale. I am looking for the pupils. The pupils are bilaterally equal and reacting to light. Now let me check the blood sugar of the child. Sir, what's the?
It is 92.
So it's 92. Okay. Let me see for if there are any rashes and any fractures and the core temperature also. What's the core temperature, sir?
37 degrees.
Are there any rashes?
No, there are no rashes.
Is there any significant on exposure?
No, there is membrane present in the neck.
Okay, there is a membrane which is present in the neck, probably in the throat. So after initial assessment, it looks that after the primary assessment, it looks that the child has a respiratory distress, and probably it is because of the upper airway obstruction, and the circulation is normal. So this child is in respiratory distress with upper airway obstruction. Now I will look for the further evaluation. I will do a secondary assessment. I will take a detailed history and a focused physical examination. I'm looking for the sample history. So what are the signs and symptoms?
Yeah, but there is history of pain and swelling in neck since 2 days.
Any allergies, sir?
No, no allergies.
Any medications the child has received?
Child has taken paracetamol for fever.
Okay, last meal?
She had something around 4 hours back.
Yeah. And when she had this noisy breathing started?
Last 4 to 6 hours.
Okay. Yeah. The visible membranes, are there any tonsil or are there any lymph nodes?
No, no, no.
So with the history and examination, I would like to ask whether she is immunized or not, because
she is not immunized.
So yeah. So this is after the end of my primary and secondary assessment. I have detected that the child has a respiratory distress and upper airway obstruction. The membranes are membranes on the tonsil with acute onset. Child is unimmunized. This child looks to have like a diphtheria-like clinical diagnosis. I will send specific lab investigations pertaining to my diagnosis and arrange for anti-diphtheria serum, and as well as prepare for endotracheal intubation if required, depending upon the resources which I have. And I will counsel the parents regarding the gravity of the problem and counsel them regarding the further treatment. Thank you, sir.
Thank you, Mandar. You managed the case very well. Next slide, please. Next slide. Yeah. So to summarize this case, important is that if you use checklist properly, then reach to a physiological diagnosis. And so the checklist helped to identify the anatomical location of the problem. That was the upper area obstructing this child. The checklist helped to identify the severity of status. The child on arrival, that was respiratory distress. The secondary assessment steps help to reach possible etiological diagnosis and further management. So remember that in any case, you use this checklist and it will be a lot of help to you. Thank you. Thank you. So for next case, I invite Dr. Meenakshi Girish and Dr. Nivedita Patil.
Yeah. Thank you so much. We have another case to go through, and I request all the participants to follow Dr. Nivedita very carefully how she is using the ALS checklist tool. Nivedita, this is a 9-month-old baby who has had coryza since 2 days, fast breathing and noisy breathing according to mother since the last 6 hours. You are in the emergency room, pediatric emergency room, and you have to manage this child. Can you please take care of this child?
Yes, madam. I'll immediately take care of this child. Am I audible?
Yes.
Yeah. So I'll begin with the initial impression. So for initial impression, I'm looking at the level of consciousness of the child. The child looks anxious and irritable. I'm looking at the work of breathing of the child. The child is breathing fast. I'm looking at the color of the child. The child looks pink. As 2 parameters fall in yellow zone, this child needs acute care. So I will gather my team and assign job to my team members. I'll ask one of my team member to start the monitor. I'll ask the second team member to start 100% oxygen with non-rebreathing mask. I'll ask one team member to get a point of care RBS done. I'll ask someone to get an IV line. Meanwhile, while all this is done, I'll proceed for the further assessment. For the primary assessment, I'm looking at the airway. So I want to see whether the airway is open or maintainable. So I can see that the airway is maintainable, but obviously I can hear that the child is wheezing. As the child is wheezing, I would like my team member to start the child on salbutamol nebulization. and I'll proceed for the further assessment of breathing. So I'm now assessing the breathing. For assessing the breathing, I'm taking the respiratory rate of the child. The respiratory rate looks around 56 per minute. So this child is breathing fast. I'm looking at the respiratory effort. So the child has increased respiratory efforts with subcostal and intercostal indrawing. I'm looking at the chest wall expansion. The chest wall expansion is equal on both sides. Now I am auscultating for air entry and adventitious sounds. So the air entry is equal on both sides, but obviously there are rhonchi heard. And on pulse oximeter, before starting oxygen, it was 91. But after starting oxygen, now the saturation has increased to 94. We have already started the child on oxygen and salbutamol nebulization. For the assessment of circulation, I am checking the heart rate of the child. So on the screen, I can see on the monitor that the heart rate is 145 per minute, which is tachycardia, fast. I'm looking at the rhythm. I can see that the QRS is narrow and P waves are seen. So this is a sinus tachycardia. I'm palpating the central and peripheral pulses. The central pulses are good. The peripheral pulses are well felt. I'm looking at the capillary filling time. The capillary filling time is more than 2 seconds. For further assessment of circulation, I am looking at the skin color. The skin color is pink. I am looking at the skin temperature. The temperature is normal. Extremities are warm. I am looking at the blood pressure. So the blood pressure is 79/49, which is more than 5th centile for this age. So the circulation is normal. For assessment of disability, I am looking at the AVPU scale. So the child looks agitated but alert. So the GCS scale is more than 12. I'm looking for the pupillary reactions. The pupils are bilaterally equal and reacting to light. Meanwhile, my team member got RBS done, which is 86 milligram percentage. So now I'll proceed for exposure. For this, I will undress the child so that I don't miss anything. So I'm measuring the core temperature. The core temperature is normal. I'm looking for any deformities, swelling, bleeding, or trauma. So there is no such finding seen on the exposure. So the conclusion of primary assessment is this child has respiratory insufficiency. The severity is respiratory distress, and probably the cause is lower airway obstruction because I could see and hear wheezing. So, but there is no circulatory insufficiency. So this child with respiratory distress and lower airway obstruction, I have already started oxygen. I have already started nebulization with salbutamol. My team member is getting an IV line. This child may need rescue steroids, so I'll keep that ready. Till then, I'll ask one of my team member to talk to the relatives, explain them the condition of the child, tell them what treatment is going on and the probable outcome. Meanwhile, I'll proceed with the secondary assessment, that is sample history. For the symptoms and sign, we got the history that the child had coryza since 2 days. There is no history of allergies reported. The child was nebulized few hours back. In the past medical history, no similar history is noted. The last meal the child was fed 4 hours back. And the event leading to present situation is the child had coryza since 2 days, but since 4 to 6 hours, the child had increased difficulty in breathing and the child is breathing fast since 2 hours. In systemic examination, no positive finding was noted. The child is immunized for age. So the provisional, the conclusion of the initial impression, primary and secondary assessment is that the child is having respiratory distress because of lower airway obstruction, and this could be multi-trigger wheeze. So I would like to, I have already started the child with oxygen and inhalation therapy. This child may need rescue steroids, but we have to plan for the long-term management of this child.
So very well done, Nivedita. With your very structured sequential approach, you have been able to identify respiratory distress with lower airway obstruction, and you have identified a possible etiology of multi-trigger wheeze. Excellent work. The child is much better now. So I hand over now to Dr. Geeta to take the next case. Dr. Geeta?
Yeah, I'm here, just waiting for the video to play. Okay, Dr. Lakshmi, Here we are in the emergency department where you have a child who is 1.5 years old who is presented with fever since 2 days, cough and breathlessness. The breathlessness is started since 1 day. So I would request you to kindly go through the checklist and take care of this child and proceed further. Dr. Lakshmi, can you hear me?
Yes,
Unmute
am I
yourself.
audible?
Dr.
Yes.
Lakshmi, yeah.
Sorry. I will like to begin with initial impression. And the child appears, consciousness-wise, he appears lethargic. He has increased rate of breathing and he has labored breathing and he appears pink. So there are 2 yellow bands activated here in this patient, and hence this child needs acute care. And I would request my team members to attach the monitor, oxygen, take a blood sugar test, and try for IV cannulation while I proceed with the primary assessment. On primary assessment, the child is having some nasal sound, so a suction was done and the airway appears maintained. On breathing, the child is having increased fast rate of respiration, and the efforts are also increased. There is bilaterally equal chest wall expansion. On auscultation, the child has bilateral lower crepitation as well as bronchial breathing. And on pulse oximetry, the child initially had a pulse ox of less than 94, but after attaching the NRM, it is now reading 100%. That is, I would like to proceed with circulatory system now. In my circulatory system examination, the child is having tachycardia, but with narrow complex heart rate. Peripheral pulses. Am I audible?
Yeah, you are audible, Lakshmi.
Yes. Yeah. So the pulses are well felt in the peripheries, and the capillary refill time is less than 2 seconds. And the blood pressure is 104 by 65, which is normal for this child. He is pink and his skin temperature is also normal. The child has, more than 5th centile blood pressure. So now I would go on to my D and E. Disability wise, child is responding only to pain, and the pupils are reacting well to light. RBS, which was done by the team member, is RBS is normal.
90.
Yeah, so it is normal at this point. I would like to now categorize my patient at the end of my AB. I have to finish my exposure. Yes, exposure wise, child is having fever and he is above 102. So I will ask for paracetamol to be given to the child, injection in that from the IV axis. And there are no obvious deformities or swellings. At the end of this, I have my primary assessment is the child is having respiratory failure. We will continue with our oxygen support and observe the child for need of ventilation. And the reason and the possible etiology is that affection of the lung parenchyma with a possible pneumonia, and antimicrobials in the form of first-line community-acquired antibiotic may be advised. The child does not have any circulatory insufficiency.
Would you like to proceed further? Yeah.
Yes, I would like to go ahead and ask the mother for the sample history. So signs and symptoms wise, as you had told, was fever for last 2 days. There are no known allergies. Medication wise, she was giving oral paracetamol for last 2 days. And past medical history, the child does not have any known diseases. Last meal, child was fed 6 hours back. And events leading was the child had developed distress, I think 3 hours since the last 3 hours. On my secondary assessment, all other systems are within normal limits. And so my provisional diagnosis is respiratory failure due to lung parenchymal disease, probably a pneumonia, community acquired pneumonia. I would advise for an X-ray test and relevant laboratory investigations. Continuing my oxygen, IV fluids, and watching out for ventilatory support.
Okay, excellent, Dr. Lakshmi. You have done a wonderful job, and using this checklist, you have nicely evaluated this child to identify that this child had a problem of respiratory failure and which was of a lung parenchymal etiology, and you have rightly identified the infective process by going into the history with the history of fever, and you have intervened so wonderfully that I am sure this child is going to be, getting better soon. And you have started the child appropriately with oxygen. You have started the child with antibiotics after diagnosing the child to be having a pneumonia. And obviously, I'm very sure that you are going to monitor this child further with your therapy to see how is the progression of the child, and you are going to reassess to see if the child needs anything further, if his respiratory failure is getting better or is it getting worsened to need the further assisted ventilation. So all in all, thank you so much, Dr. Lakshmi. You have managed this child wonderfully, and I am sure this child is going to be home soon. So now I invite to the next speakers, Dr. Swapnali Bansode and Dr. Meenakshi Girish for the fourth case.
Thank you, ma'am. Good afternoon, everyone. So we'll start with the case number 4. So, ma'am, you have a patient, a 16-month-old child who had seizures at home and it is brought to emergency in post-ictal state with the difficulty in breathing. Now you are called upon. Kindly examine this child and use the checklist provided with you. Thank you.
Yeah, so this child has just arrived, and with my initial impression approach, I see that the child is unresponsive. And when I do a CBC, I find that the breathing is very slow. And the color, when I look at the color, it is cyanosed. So this child, based on my initial impression, is not a stable child. He falls into the yellow zone category, that is child requiring urgent care. And from that point of view, I will quickly call a team. I will tell somebody to apply a monitor. I will ask someone to do a blood sugar, start an IV cannulation, and meanwhile, and start oxygen. While all this is being done, I would like to proceed with my ABCDE assessment. So first I look at the airway. Now when I see the video, I find that the child's chest is expanding well. So the airway is open, though I see some secretions. And so even I will just do a suction, but I'll make sure that the suction is less than 10 seconds. Now I move on to breathing. And on breathing, I look at respiratory rate, effort, chest wall expansion, I auscultate, and I look at the saturation. So when I look at the respiratory rate, obviously everyone can see that the rate is very slow. And when I look at the effort, the child has decreased effort of breathing. Then I look at chest wall expansion. I find that though the expansion is symmetrical, but there is decreased expansion. When I auscultate, I find that there is no abnormal sounds, but the breath sounds are diminished. Now with this, I quickly tell my team member to start arrange for positive pressure ventilation. And I look at the saturation. I find that the saturation is less than 90%. So I would like to start bag mask ventilation with 100% oxygen. While this is being arranged, I go on to assessment of circulation. I see in the monitor that the heart rate is shown as 133, and when I examine the patient for capillary filling time, I find that the CFT is normal, it is less than 2 seconds, and the color is pink. So I check the blood pressure on the monitor. I find that the monitor shows a blood pressure of 84/50. For a child who's 16-month-old, I need a systolic BP of more than 70. So this child is normotensive. I move on and I now look at the child's disability. So from primary assessment, I have done A, B, and C. I move on to D. In the ABPU scale, this child is not responsive. He is probably unresponsive to voice and to pain. And his pupils are normal, symmetrical, and reacting to light. On exposure, as I see the child's exposed body, I don't see any rash and I don't see any joint abnormalities. I find that the child's temperature is normal. There are no bleeding from any side. So I have just completed my ABCDE assessment while the child is on intervention with bag and mask ventilation with 100% oxygen. I conclude based on my primary assessment that this child is actually in respiratory failure, and I have already started assisted ventilation. There is no circulatory insufficiency. This respiratory failure is most likely due to disordered control of breathing because there is slow breathing and because of the so there is no circulatory insufficiency. So while I stabilize the child's respiration, I would go on to secondary assessment. I will go out to counsel the family regarding the child's condition, and I will move on to secondary assessment. Dr. Swapnali, I have started initial stabilization. Once the child is stabilized, I will do the detailed secondary assessment.
Thank you. Well done. You have successfully identified and evaluated the disorder control of breathing. So for the summary of this case, whenever a child is having ineffective breathing or there is a severe respiratory distress associated with cyanosis or altered sensorium, we will label this as a respiratory failure. And when there is a neurological cause for abnormal and ineffective breathing, we can call it as a disorder control of breathing. Now, this was a case of respiratory failure and child required immediate care and assisted ventilation. So we can start with the assisted ventilation irrespective of the cause. And after finishing the assisted ventilation, we can go to the secondary evaluation after assisting the child. Thank you very much, ma'am. Now I would like to invite Dr. Rohini Ingole and Dr. Geeta Bhatt for the case number 5.
Thank you, Dr. Swapnali. Dr. Geeta?
Yeah, Dr. Rohini.
Dr. Geeta, this 1.5-year-old girl was brought by her mother with complaints of loose motions and vomiting since one day and lethargy since last 6 hours. So kindly attend to this child with using your checklist and demonstrate how would you proceed.
Yes, madam, I will surely proceed for the child. I would first like to have my initial impression. So this child in consciousness appears to be lethargic. His breathing, when I check at the breathing, appears to be normal and his color appears to be pale. So this child is having in 2 red zone criteria. So this child definitely needs acute care, and I will gather my team and assign the roles. I will ask the team member to attach the monitors and start this child with oxygen by an NRM with a flow of 10 to 12 liters per minute. And I will also ask my team members to start this child vascular access, and at that point of time to collect the necessary, collect the blood for the necessary investigations with regards to first and RBS to check with. And while they are doing with this, I would like to proceed with the primary assessment. So in primary assessment, I would like to check for the airway. This child's airway appears to be open and appears to be clear. So then I would move to a second part of the primary air assessment, that is breathing. When I'm counting the rate of this child's rate looks to be 32 per minute, which appears to be normal. At looking at the effort, respiratory effort, there is no increased work of breathing. There are no use of accessory muscles. So that appears to be normal. I'm seeing the bilateral chest wall rising well with the breathing. So the chest wall expansion appears to be good. When I'm trying to auscultate this child does not have any adventitious sound and air entry is bilaterally equal. When I'm looking at the pulse oximetry, the SpO2 initially was 87, and after I have intervened by starting this child on 100% oxygen with NRM, this child saturation has increased to 94. Then I would move to assess the circulation part, where I would like to assess the heart rate. The heart rate seems to be in range of 150, so definitely this child has tachycardia. When I'm looking at the monitor to see the complexes, the rhythm appears to be having a narrow complex rhythm with P wave present. So this looks like to be a sinus tachycardia. Now I'm palpating this child's pulses. The central pulses are felt, but the peripheral pulses are weak. So definitely this child has compromised circulation. Quickly I assess for the CFT and it appears to be prolonged. It is 4. When I am looking at the color, the child definitely appears to be pale, and the environmental temperature being normal, when I am assessing the extremities, the child's extremity appears to be cool. And the monitor is showing the BP, which is 60. So definitely this child BP is less than what is expected for his age, above 70. So this child is having a hypotensive shock, the severity being, and the probable etiology with this history of loose motions and vomiting looks like an hypovolemic type. So I quickly ask my team member to administer the fluid bolus. With the length-based measurement tape, this child's weight appears to be 10 kg. So I will ask them to start 20 ml per kg, that is 200 ml of normal saline to be pushed in. In the meantime, when I'm trying to see whether they have accessed the vascular access, I come to know that after 2 attempts of trying to access the vascular, the child's IV could not be found. So at this point of time, we have attempted an intraosseous line, and the fluid bolus is administered through intraosseous line. Now, why an intraosseous line? Especially such situations where you have the situations of an cardiac arrest or a child who is absolutely in shock with a volume loss. If 2 attempts or having an intravenous access failed, one must go for an intraosseous line because it is an access to a non-collapsible venous plexus. So this is the right indication for going ahead with it. While going with the procedure of it, I would like to just narrate the procedure, how we will do it. The commonest side being the tibia. So anterior surface of the tibia, and the exact position will be 1 to 2 centimeter below and medial to the tibial tuberosity. While giving the position, the child's leg should be slightly flexed and stabilized. And after taking the sterile precautions and painting and draping the correct site, I would use either the bone marrow needle, intraosseous needle, or if they are not available, I will use the number 18 or number 20, that is wide bore needle. And when I'm going in, I would be going in perpendicular to the bone with a screwing motion, inserting into the bone till I feel a give way, resistance to give way. So at that point of time, why there is a give way? Because my needle is entered into the bone marrow. And then once I have that give way, I can confirm it by trying to aspirate the marrow. And then I fixed the needle with an adhesive tape. And intraosseous access is the best because it can be administering the fluids, especially when there is a need of fluid resuscitation. And also all the medications, IV medications can be given through it. Once I have an access of peripheral line, that is say within the next 24 hours, I would remove my intraosseous line and then the peripheral access would be established. And once I take an intraosseous line, I would be always watching and confirming whether there are any complications with that. I would like to see if when I start to run the fluids, whether there is any swelling or anything which is beyond on the posterior aspect of the leg or around the intraosseous line, which will suggest that there is an IV extravasation. In that scenario, I have to remove it and try and put it in the other site. So we have done this intraosseous line and my team member had administered 200 ml of normal saline. And then by the time this has been done, I would definitely proceed with the third part of the primary assessment, next part of the primary assessment, that is disability. In the meantime, once the 200 ml of saline is pushed in, I will definitely want to again reassess this child so that I have kind of complete this criteria of evaluate, identify and intervene, because this child would need a reassessment to see whether this child is showing any progress. Now, in between, I would move on to the primary assessment, that is disability, to see what is the child's consciousness level, cortical functions, and this child is responsive to pain. So the GCS appears to be 8 to 12. At this point of time, while doing an intraosseous, we have done the blood sugar, which shows the 90. So I don't need to take care of any hypoglycemia at this point of time because this child's sugars are maintained. Then I move on to the pupils, which are bilaterally equally reacting to light. Then I move on to the next component of the primary assessment, that is exposure. In exposure, this child, basically, I will remove the clothes to see if any deformities, any bleeding or any external rashes are present. There are none noticed for this child, and child's core temperature is normal. So I have completed here my primary assessment, and at this point of time, my conclusion is this child is in hypotensive shock, the type being hypovolemic shock, and the etiology being the fluid losses because of the vomiting and the diarrhea which this child had. So I have already intervened this child trying to administer the oxygen because he had a shock, and we have also started the fluid resuscitation with the normal saline. And I would like to reassess after the fluid bolus, and if the signs of poor perfusion still persist in the form of tachycardia, capillary filling time prolonged, with the BP still being on a lower side, I would give the second bolus, which is again 20 ml per kg of normal saline, that is 200 ml of normal saline. In the meantime, this has been done. I will proceed to the secondary assessment, and I would like to go in the history of this child to find out what are the signs and symptoms. And the signs and symptoms for this child was, this child had a history of loose motions and vomiting since the 2 days. The allergies, when were explored, there were none. The medications, the mother had given the home-based medications. Past medical history is absolutely non-significant for this child, and the child had taken last meal in the previous night. And the events which were leading for this was, this child had a large bout of vomiting, and the child became lethargic and was brought to the ER department. After completing the history, I would like to go into the focused examination, the rest of the head to toe examination, and I have done that, and that seems to be completely within the normal range. So in the meantime, I have asked one of the team members to tell the parents what has been going on with the child and what seems to be the likely problem with the child and what are we taking care of, so that parents have been counseled. And when I probe a little bit into the detailed history to know what is the etiology of the loose motions, it seems to be this child has been bottle fed. So we address that issue also, asking them not to bottle feed. And at this point of time, my provisional diagnosis for this child after the completion of assessment is, as I already said, it's a hypotensive shock due to hypovolemia, the etiology being fluid losses because of vomiting and diarrhea. So I have done the necessary interventions, and while putting an intraosseous line, we have also collected blood which have been sent for the electrolytes, and any derangement of the parameters would be addressed, and this child is started on oxygen with saline boluses. And of course, this child would need a monitoring to see how child sensorium improves and how child circulatory parameters improve.
Well done, Dr. Geeta. You have done a wonderful job. You have successfully evaluated and identified the hypotensive shock with hypovolemia as a possible etiology, and effectively intervene in the short period of time so the child could be saved. So here we have seen that the use of this checklist have helped us to identify the signs of poor perfusion and shock, and also determine its severity within few minutes of arrival of the patient. Also, we could find out the type of the shock by history of losses as hypovolemia, and the child received appropriate intervention in a short period of time, and the life was saved. Thank you, Dr. Geeta. I would like to invite Dr. Sagar and Dr. Anjali for the next case.
Hello, madam. You are in the ICU, pediatric ICU, and this is a 1.5-year-old child who was in the ICU, is on the ventilator, and he suddenly started deteriorating. Now, you please take care of this child using the IV ALS tool.
Yes, sir. Thank you very much. I will certainly immediately take care of this child. Now, my initial impression, I'll start with my initial impression, that is CBC. C, conscious, he looks to be irritable, agitated. B, breathing, he is on ventilator. Okay, so you can't know what it is. Then color, C, he looks to be pale. So now, next slide. So all his three limbs have come into a yellow category, that is acute care needed. I will gather my team, assign jobs to arrange everything, but already he is on monitor, he is on oxygen, he is on IV cannulation. So I will proceed with my detailed assessment. So I will go ahead with my primary assessment. Okay, in my primary assessment, I will go for my airway. Here the airway is on ventilator. That means it was unmaintainable. Now I will go to my next B. Okay. No, the previous slide. Sorry, the previous slide. Go back. Yeah. So here now he is on ventilator and now he is started deteriorating. So immediately what will strike me is a mnemonic called as DOPE, DOPE, displacement, obstruction, pneumothorax and equipment failure. So my first thing what I will do is I will remove him from the ventilator and I will start doing bag and the ET tube ventilation. So in that way now I have reduced the possibility of equipment failure. The second thing, I will see whether his ETT is at 4 millimeters, which is for his age, and it is fixed at 12 centimeter. And there is a mist present. So that means it is not displayed. So I have ruled out the second possibility of displacement as a cause of deterioration. Now, third thing, I will go for his obstruction. Can you go for the next slide? Now in breathing, his respiratory rate is taken care of my ventilation. It is 20. Respiratory efforts are decreased. The chest wall expansion is decreased. The air entry auscultation
The
is
air entry
diminished.
is, it is found that the air entry is decreased on the right side of the chest.
Okay, so air entry is there. It is decreased on the right side, but it is present on the left side. That means I have ruled out obstruction as a cause of his deterioration. Now, what is his pulse oximeter?
Pulse oximetry was showing 75% and 100% oxygen.
Okay, so the pulse oximeter is showing 70, so it is less in 100% oxygen. Now his chest wall is decreased, there is decreased air entry on the right side and the pulse oximeter. So now I have come to a conclusion that this child is deteriorating. The reason is pneumothorax. Now there is a dictum. If you find any life-threatening situation while you are assessing your primary assessment, you have to stop your further assessment, that is D, C, D and E, and I will tell my team immediately to start the treatment. The treatment is a needle decompression in the second intercostal space on the right side in the mid-clavicular line. And immediately after that, I could hear a gush of air coming out. And now I have also advised my team to do an underwater drainage seal for this child, chest tube drainage. Next slide. While this is going on, my team is taking care of this child. I will now go to my circulation. The heart rate looks to be slow. Rhythm.
Rhythm is normal, madam.
Normal, okay. Now, how are his peripheral pulsations and central pulsations?
They are decreasing the volume.
And CRT is?
More than 2 seconds.
It is more than 2. So I have again come with another complication like the life-threatening, which is an hypotensive shock here. So I will again advise my team to give a bolus of only 10 ml of normal saline. Why 10 ml of normal saline? Because as I have put a needle, the pneumothorax has been taken care of and then the cardiac output is increased. So I will not go and give 20 ml, but I will just tell them to give a 10 ml of normal saline. Next is the skin color. His skin color is, it looks to be little pale. Skin temperature. is okay, cold, and his systolic blood pressure
64/30.
60. So he is in hypotensive shock. It is less than 5th percentile. Okay, so next D. So as I could find a life-threatening situation, I have deferred my D and E, but by this I could come to a conclusion. Next slide. I have come to a conclusion that this child was in respiratory failure and he was in hypotensive shock as a severity of your respiratory and circulatory insufficiency. And what is the real type now? The type is an obstructive shock. But why has he gone in an obstructive shock? The reason is a pneumothorax. So I have come to this conclusion, sir. And my team is taking care of his chest tube drainage now.
Thank you, madam. It was the excellent diagnosis and treatment of the child which has saved his life. So to summarize this case, if the child has got a sudden deterioration in a ventilated child, always think of DO, and you need to evaluate everything properly. Pneumothorax was the case in this child which was properly treated, and the child also had a hypotensive shock which was managed with the IV fluid. So intervention was again in the ABC sequence with the pneumothorax drain, resulting in the immediate improvement in the shock parameter here. So you always need to think of airway and breathing before taking the circulation. So always think of pneumothorax in deteriorating child. If you treat it properly, it is a life-saving to the child. Thank you, madam. Next case, I would like to ask Dr. Manish Joshi and Dr. Nimbalkar sir to take the next case.
Thank you very much.
Good afternoon, everyone. Good afternoon, everyone.
Good afternoon. Dr. Somsekar, I'm giving the scenario where there's a 2-year-old male is come with a history of fever, vomiting, and refusing to eat since the last 2 days, increasing in the last few hours. Kindly manage this child.
Thank you, Dr. Thank you, Dr. Manish, for asking me to manage this child. If you can see, as the initial impression based upon the IAP advanced life support algorithm, we can see that the baby is agitated, but irritable and lethargic. And we can see that the baby has fast and labored breathing. And we also can see the baby is not pink and definitely a little bit motor cynos. So since all of the values that you can see are in the amber zone, I will go ahead and manage according to how we manage the amber zone patients. I'll gather the patient requires acute care, and I'll gather my team and assign the job to arrange for like various monitors, make sure that the baby gets oxygen by non-breathing mask, 100% oxygen. We'll try and do an point of care RBS and set up IV cannulation, preferably 2 large bore lines, and then continue to proceed with detailed assessment. Next. Hello. Yeah. So as I go ahead and start assessing the airway, we can make out that the baby's breathing is fast and there appears to be no sound, and hence it is a clear and maintainable airway. After assessment of the airway, we would go forward to assessment of breathing. As we can see, the rate of breathing is rapid. You could probably have around 55 to 60 breaths per minute, which is high. The respiratory efforts are obviously increased. The chest wall expansion appears to be equal on both sides. And are there any crepitations or breathing, or what is the air entry like in this patient?
The air entry is bilaterally equal on both the sides.
Okay, air
No,
entry is equal, so there are no crepitations. Okay, and then so what we do next is you can see that the saturation is high, more than around 95%, and probably was low previously. And so as far as the breathing assessment is concerned, the baby does have labored breathing or increased work of breathing, which is there. After managing this, after assessing this, we go on to assess circulation. In terms of circulation, we will have, can I have the next slide, please? We will assess for the heart rate. As you can see here is 190, which is definitely high. The ECG is not visible, but I guess it is narrow complex heart rate. And the volume of the pulse, can we have, what is the volume of the pulse in this patient?
There are bounding central and peripheral pulses.
bounding central and peripheral pulses, and I'm guessing that the CFT would be 2 seconds or less in such a
CRT
case.
is less than 2
Is that
seconds.
correct?
Brisk, it's a brisk
Yes.
CRT.
So this circulation. After assessing the circulation, can we have the next slide, please? What we have realized, the skin color that is mottled. We saw the temperature of the baby is warm, 100 and looks like febrile and
Yeah, this fever, the
systolic blood
child is
pressure.
103. The blood pressure is
Blood pressure,
74
we can see
systolic. 74 systolic.
74 systolic. The age of the child is
6
2
months.
years and 2
years.
6 months.
Sorry, it is 2
years.
years. Yeah, it is 76 systolic. 76.
Yeah, so 76 systolic. So the systolic blood pressure is more than that of what we expect. So the baby does not have what we call as what we would put as hypotensive. So go ahead. The baby definitely is in shock, as we can see. Can we have the next slide, please? If you look at the disability, the baby is agitated, but the GCS score is 8 to 12, and pupils. What is the status?
Normal.
Pupils are bilaterally equal and reacting to light. And on the RBS, if we have by now, what would the RBS be?
70.
What would the RBS be? 70. So
70.
Random blood sugar also is normal. The temperature mentioned was high, 102 degrees centigrade, and as we saw earlier in the introduction, that the baby has rashes, especially in the lower limbs of the body. Based on the information that we have gathered so far, we saw that the baby required acute care, and we started baby on oxygen and monitors, etc. And the assessment of breathing, airway was good. The breathing you can see is labored, and the circulation, we do know that the baby is in hypotensive shock. So if you look at this, we can definitely say, as far as the respiratory system assessment is concerned, the baby is in respiratory distress. While the blood pressure is normal, the systolic is above what we would consider as normal, the baby still has circulatory insufficiency, and hence baby has poor circulation. Baby is in shock. Based on the history that is received and the bounding pulses and the CRT of less than 2 seconds, and the fever that is present with the history of vomiting, etc., which is there, we could assign the cause of sepsis as being distributive shock or sepsis. It is a distributive shock, probably because of sepsis in this particular patient. So now, after we have finished the primary assessment, we will go on to the secondary assessment. As far as the secondary assessment is concerned, we would want to know what are the signs and symptoms in this patient. The child had fever in the last 36 hours and developed these rashes in the last 18 hours and has been increasing rapidly. Does the baby have any allergies from the previous?
No.
Do we have any allergies? No allergies in the baby.
No allergies.
What medications is the baby on?
Paracetamol was given sometime back.
Paracetamol was given, and so it is important to know how much paracetamol was given, because if baby still has fever, and we would have to give another dose if there has been a big gap between the previous dose. Domperidone for vomiting. Any past medical history that I should know of? Any prolonged history? No significant history. Has received immunization. As per government schedule, which means H influenza and pneumococcal vaccines would probably have been received, depending upon which state he is in. And any last meal that was taken?
Some time back, little milk was taken,
and that was vomited. Okay. So, and any events apart from the fever that has happened in the previous time?
So fevers in the last 2 days, increasing breathing difficulty and unconscious and decreased sensorium in the last few hours, and vomiting.
Okay. So based upon whatever history we have, we can kind of come to a probable respiratory, ALS physiological diagnosis of hypotensive distributive shock and respiratory insufficiency, and this baby requires immediate management. So we will look at we would have already started IV fluids, and based upon the assessment that we have done so far, because there is no other finding on the tertiary care examination, we would go ahead with giving antibiotics for this particular patient, because we expect that this patient is septic. But before that, we would draw blood for counts and culture and X-ray. Oxygen we have already started. We would ensure that we give a saline bolus of 20 ml per kg rapidly over a period of 10 to 15 minutes and reassess the circulation and continue to manage giving fluids. If the blood pressure drops and requires more further support, we would continue to monitor the baby's blood pressure and give inotropes as required. Important to know that since this is a septic shock, baby might and the baby is in shock, a lot of oxygen requirement is there by the respiratory muscles. So if needed, it might be a good idea to take over ventilation of the baby by intubating the baby and ventilating the baby so that the oxygen demand of the body drops and shock improves. So this is the way, and after you stabilize the child in the emergency room, because this patient is in the emergency room, we would then hand over the baby to the PICU for further care and assessment and for ongoing care.
Very good.
Exactly.
So thank you, Dr. Shamsekhar, for having managed this child very well. The points to be noted here is that the diagnosis of shock was made by sluggishness of circulation and by tachycardia. The type of shock was diagnosed by the presence of bounding pulses, fever, a brisk CRT, and rashes on the body. However, the severity of the shock is diagnosed by the blood pressure. My apologies, in the case I mentioned it's a normotensive shock, but here it was a hypotensive shock. The Q I gave was a little wrong. The blood pressure was 72 centimeters, that is why it was in hypotensive severity. So
the management wouldn't change. The management wouldn't change, right?
Yeah. So here we have a shock which is of a distributive variety, and the further treatment will, as sir has already explained, that treatment is being continued, and it will also require fever management, getting the metabolic demands of the patient down, and further on. So thank you very much, sir. Thank you very much. We finish this case over here, and I invite Dr. Nivedita and Dr. Swapnali for the next case.
Hello, Swapnali, are you there?
Yes, ma'am.
Can you hear me?
Yes, ma'am. Sure.
Yeah. Dr. Swapnali, here is a 2-year-old child who had cough, coryza, and low-grade fever since 3 days. And since last 4 to 6 hours, the mother says the child is lethargic, he's not feeding, and he's breathing fast. So with the help of this tool, how would you manage this case and demonstrate how you would proceed to manage this case?
Thank you very much, ma'am. Now I should proceed with the initial impression for this child. So I am looking at the child, and while looking at the initial impression for the CBC, when I look for the consciousness of this child, the child looks lethargic. When we look for the breathing of this child, the child breathing is labored. There is and there is some adventitious sounds we can hear, that is a grunting sound. And when you look for the color of this child, the child looks a bit dusky or silenced. So the 3 parameters fall into the yellow zone. So acute care is needed for this child. Ma'am, I would like to gather a team and assign them the job. So I will ask one person to attach a non-rebreathing mask and give 100% oxygen through that. And after that, we will attach the monitors and look for the cardiac functions also. Then, ma'am, after the completion of the primary impression evaluation, we will continue with the primary assessment. Primary assessment of the airway. The airway looks to be open, so I will just continue with the supported breathing. When I assess for the assessment of the breathing, when I look for the respiratory rate of the child is 56 cycles per minute, which is very fast. When I look for the respiratory efforts have increased. There are some intercostal and subcostal retractions visible. When I look for the expansion of the chest wall, the expansion of the chest wall is equal on both sides and normal. When I auscultate for the air entry appears to be normal on both sides, but I could hear some crepitations on the posterior basal areas. We have already attached the monitors. When I look for the pulse oximetric examination, the SpO2 before the starting oxygen at room air was 94%, and after starting the oxygen, it has improved to 100%. So primary assessment for the breathing is concluded. Now we should continue further with the primary assessment for the circulation. On the monitor, the heart rate is shown is about 181, which is very fast for the age of this child. When we look at the rhythm of the ECG leads, the QRS complexes appears to be narrow, and I can see the P wave. So it is a sinus tachycardia for this child. Now I would like to examine for the central and peripheral pulses. So central pulses on palpations are palpable nicely, but the peripheral pulses are in decreasing volume. So when I look for the capillary refill time, the capillary refill time is more than 2 seconds. For further continuation on the assessment of circulation, I look for the color of the child on exposure. So the skin color of the child appears to be cyanos or dusky. On examination, the skin temperature is extremities, though the environmental temperature is normal, the extremities appears to be cool. When I look at the monitor, the blood pressure of this child is 82 by 56 millimeters of the mercury, which is more than 5th percentile for this age. So at the end of circulatory assessment, we come to know that this child is having a shock, which is normal in blood pressure. So this is a normotensive shock. So we have already started with the IV access and oxygenation. I would like my assistant to give the fluid normal saline, but the bolus will be very slow and it will be only 5 milligrams per kg because the blood pressure is normal and it is a normotensive shock, and we do have, and this shock is associated with grunting. So I would not further give the bolus. If the patient is not improving, I will ask my assistant to keep the inotropes needed, inotropes ready if at all it is needed. On the further assessment for the disability, the child appears to be lethargic. So I would like to know whether the random blood sugar has been taken. Yes, the random blood sugar has been taken and it was normal. So I'll continue with the examination of pupillary responses. So pupils are normally reacting to the light on the both sides. So I will further continue my examination to the disability. So on further examination, the core temperature of this child is normal. When I look for the deformities, I could not find any abdominal distension, any congenital malformation, any bleeding site, or the rashes. So we have completed our initial assessment, primary assessment. So after the completion of the primary assessment, I come to the conclusion that the child is having some respiratory insufficiency. So there is a respiratory distress, for which I have already started the non-oxygen by non-rebreathing mask. When I see for the circulatory insufficiency, there is a shock, but blood pressure is normal, so there is a normotensive shock. And when we look for the type of shock, as there is no definitive history is present with us, and the shock was associated with grunting, so we can probably think that it is a cardiogenic shock. So when we think it is a cardiogenic shock, we will not overload the child with the fluid. So slow 5 ml per kg fluid will be given to the child. And if it is the child is not improving with the fluid bolus, I could start with the inotropic support. After doing the primary assessment and doing the needed interventions, I would like to process further with the secondary assessment and focus of my assistant or helper to go to the parent and ask for the history of the child. When we look for the history, the signs and symptoms of the child are, so mother gave us history of the child was not keeping well since about 7 to 10 days. When we asked for the allergies, there was no history of any allergies. When we look for the medication history, the medications, no medications were given to the child. When we look for the past medical history of this child, the child was treated for the upper respiratory infection for about 2 weeks back for 3 days. And when we further inquired for the last meal, it was given in the last night, and child was not eating, feeding poorly since today morning. And the events which lead the child to emergency room was the noisy breathing with decreased activity and poor feeding since today morning. The next slide. After finishing the secondary assessment for sample, I would like to go for the focused examination of the systems. When I look for the cardiovascular system, I could hear the muffled heart sounds. and there was a gallop rhythm present. And on per abdominal examination, child had hepatomegaly of 4 centimeter below the costal margin. So with this evaluation history and examination, I would like to come to the conclusion that this child is suffering from respiratory distress with the normotensive shock, which may be of cardiogenic origin. So to confirm the shock of the cardiogenic origin, whether it is a viral myocarditis or dilated cardiomyopathy, I would like to further investigate this child pertaining to the same, like 2D echo, ECG, or troponin examinations. So for the management of this child, as the child had respiratory distress, the child was given oxygen supplementation. And for the shock, because the child was in shock, we have started with the slow 5 ml bolus, 5 ml normal saline. If the child does not improve with the normal saline and inotropic support, this child may need the elective ventilation. So I would like to transfer this child from the ER to the pediatric intensive care unit for the further assessment until the child's distress settle. Thank you, ma'am.
Okay, congratulations, Dr. Swapnali, for successfully managing this case. So we have seen that cardiogenic shock can present with non-specific complaint with no fever or history of very mild URI about 2 weeks back. It presents with respiratory distress with grunt and poor perfusion. While all other shocks have silent tachypnea, cardiogenic shock has respiratory distress. So still this child would need IV bolus of slow like 5 ml per kg to optimize the circulating volume and along with inotropes. The child may need elective ventilation, as Swapnali rightly said. If the child does not respond to oxygen and inotropes, we have to ventilate the child electively to decrease the metabolic demands. So we have seen that the checklist is easy to use. It helped to identify respiratory distress at initial impression. It helped to identify normotensive shock along with respiratory distress at the end of primary assessment, and at the end of the secondary assessment we could reach to the etiology of this physiological derangement, that is cardiogenic shock. So checklist prevents missing out on any important step. So thank you, Dr. Swapnali. We will proceed to the next case. I invite Dr. Sandeep Golhar and Dr. Manish Doshi to carry the next case, that is case number 9. Thank you.
Thank you, Dr. Dr. Nivedita. Am I audible?
Yeah, sir, you're audible.
Yes. So, Dr. Manish.
Yes, sir.
This is a 12-year-old child who has suddenly collapsed while running in the school. He was participating in an athletic meet and is brought to your care. How would you like to proceed?
Sir, I would like to do my initial impression and I would like to look at the appearance of the child.
Very good.
Is the child responsive?
The child is unresponsive.
So, sir, if the child is unresponsive, then I will abandon my ALS protocol and I will go on to the BLS algorithm. So, in the BLS algorithm, I have my team along with me, and I will check for a pulse. If the pulse is absent, then I will put the child. I'll expose the child, put him on a firm flat surface, and I'll ask my team members to start a high quality CPR. I will at a rate of around 15:2 because I'm not able to find any pubic hair or axillary hair.
Yes.
Meanwhile, I'm told the CPR is started at the rate of compression and ventilation is at the rate of 15:2. Other team member is putting on the cardiac monitors. One team member is getting an IV access, and I have sent one team member to get a detailed history because that will come important in this case. Sir, the monitors are up. Is there a rhythm visible on the monitors?
You'll get the rhythm right now. Please change the slide. How does this rhythm look like?
Yeah, this rhythm is the irregular rhythm. It consists of ventricular fibrillation. So, in the ALS pulseless algorithm, I will go on to the algorithm where it is a shockable rhythm. So I will ask my team members to prepare for the shock. Meanwhile, I will give 0.1 ml of 1 in 10,000 solution of epinephrine. If the shock, by now, see, that's continued. My team is ready with the defibrillator. So I would like to give a defibrillating dose of 60 joules per kg, 60 joules because the child appears to be around 30 kilos in weight. So after the shock has been delivered, next slide.
Yes, we'll play this video of
Take out the pads and convert the pads into pediatric mode. All defibs have pediatric pads under their big pads. So we'll consider that this is a 10 kg child and we'll select an energy of 20 joules, 2 joules per kg. Jelly. All clear? All clear. Charge. Delivering shock. CPR continue.
After the shock is delivered, we will continue the compressions. We will keep on giving IV epinephrine every 3 minutes to this patient. At the end of 2 minutes, we'll change the people giving the compression and managing the airway, and prepare for a shock. If the child after 2 minutes, prepare for shock and a pulse check.
Very good, very good. So even after 2 minutes, please go to the next slide, please. So what are the entities you are likely to encounter in such situations?
Right, sir. So in this patient, where there is a pulseless arrest, we would like to keep in our mind that there are the various possibilities where the causes of this kind of a situation. So in which I would like to rule out all the H's and T's. Here, yes. I would like to see, here I am seeing that the hypoxia is absent because we are ventilating it with 100% oxygen. There is no history, by now the history has come. There is no history of suggestive hypovolemia. The child was playing around when it happened. The blood gases are normal. The sugars have come by now, which is normal. There is no hypothermia, and the electrolytes are also normal. Regarding the T's, there is a history of trauma, so we'll keep in mind whether there is something like a tension pneumothorax or a cardiac tamponade. There is no I'm oscillating and seeing that the air entry in both the sides is normal, so there is no tension pneumothorax. There is no history suggestive of a thrombotic phenomenon. There could be a primary electrolyte abnormality, primary conduction abnormality, or there could be a possibility of a drug poisoning, which we'll keep in mind.
Yes.
By now.
Very good. Now we'll give you the result of your intervention. Please play the next slide.
So when I see this rhythm on the monitor, I will immediately do a pulse check. If the pulse is present, that means there is a return of the spontaneous circulation. If the pulse is absent, then I would like to call it as a PE and further manage it.
Yes, excellent. So there is a return of spontaneous circulation. The child has been managed very well. Now, points to be remembered is defibrillation is the delivery of unsynchronized shock during cardiac cycle to terminate an abnormal electrical activity. It is indicated only in VF and PVT. For children under 8 years of age, we use manual defibrillator. You can use adult AED also, but for children greater than 8 years of age, you use adult defibrillator. In absence of any defibrillator, you should start using AED or a manual defibrillator with adult pads. The pediatric dose, as has already been mentioned. When to use drugs? Hello? When to use drugs?
Yes, sir.
When to use drugs?
So we are the drugs that we are using is to begin with IV epinephrine. So, we keep on giving IV epinephrine every 3 minutes. Beyond that, if we need further drugs, then we can use IV amiodarone and IV lignocaine.
Yes, perfect. Very good. So please change over to the next slide. So in summary, incidents like this are reported, though rarely during athletics event. So in such cases, your history might be there. So of young stroke, of young infarction. It is important to differentiate shockable from non-shockable rhythm. So this was a shockable rhythm by BLS protocol. Defibrillation is a mainstay of treatment of shockable rhythm apart from drugs like epinephrine and amiodarone. Your IAP BLS algorithm help us to get us to the correct steps of resuscitation, and defibrillation will be taught separately during IAP ALS courses. Thank you, Dr. Manish.
Thank you, sir.
Now I invite Dr. Ashish Lothe to continue with core case number 10.
Thank you, Dr. Sandeep. Dr. Vaswani, madam?
I'm here.
Can you hear me?
Yes, yes. Am I audible?
Yes, madam.
Yes.
Yes, madam. Yes.
Good morning, everyone.
Yes. So we have got a 3-year-old child with an underlying complex congenital heart disease in post-operative ward, gets suddenly unresponsive in your duty. How would you like to proceed?
Thanks, Dr. Ashish. I'll start immediately managing this case. Starting with my IAP ALS tool, initial impression, I find that the baby is unresponsive, hardly any breathing or either gasp in between, and the child is pale. So since the child falls in the red zone, I will abandon all my further evaluations and go directly with CPR. Proceeding with CPR according to the IAP BLS algorithm, I have started with chest compressions. In the meantime, I gather my team and ask them to attach monitors, start bag mask ventilation with 100% oxygen, check for RBS, get an IVO access, and someone can go in further for detailed interrogation or history taking. So now,
Hello? Hello? Vaswani madam is not audible.
Hello?
Hello, I think there is some connectivity issue. She's not audible.
Yeah. Hello, Dr. Vaswani, madam?
Sir, you can carry on the case, sir, instructor. Instructor can carry on the case.
Okay, right.
Till she joins back.
Yeah. So we had seen madam had made her initial assessment, child was unresponsive, and then he needed urgent CPR as he was not breathing, child was looking pale, all 3 parameters were in red. So this child was in cardiac arrest. And central pulses were not palpable. I have started chest compressions. One of my teammates is counseling the attendants about the need of CPR and possible outcome. And other teammate is providing bag and mask ventilation with oxygen. And the nurse is attempting vascular access to IV fluids. So we are checking the rhythm. The rhythm shows it is ventricular tachycardia. And as there is no pulse, we have to follow the cardiac arrest algorithm. This is a shockable rhythm. So we will administer defibrillating shock at 2 joules per kilo. The child is roughly 10 kg. So we have selected 25 joules, nearest rounded figure. So can we play the video?
Install the defib on the manual mode. Take out the pads and convert the pads into pediatric mode. All defibs have pediatric pads under their big pads. So we'll consider that this is a 10 kg child and we'll select an energy of 20 joules, 2 joules per kg. Jelly. All clear? All clear. Charge. Delivering shock. CPR continue. Switch on the defib on the.
So we'll continue CPR once shock is delivered. The next step as per algorithm is IV adrenaline, which is to be repeated every 3 to 5 minutes. So we'll take 1 ml of 1 in 1000 adrenaline, dilute it with 9 ml saline and give the required adrenaline dose. So again, we'll check rhythm. So rhythm is same. It is ventricular tachycardia with without any pulse. 2 minutes have passed, so chest compressor and airway persons will change their position. So rhythm is same. So would give another DC shock. This time double the dose. That is 4 joules per kilo. This time I have chosen 50 joules as the dose. Can we play the video again? I think the video would be
There's no
same.
video. There's no video.
Yeah, there's no video. And CPR would be resumed immediately again. Meanwhile, I will also check for correctable causes, that H and T's. The H include hypoxia, hypothermia, hypoglycemia, low pH hypoacidemia, hypoglycemia, hypo or hyperkalemia, as well as T's like tension, pneumothorax, tamponade, toxins, trauma, and thromboembolism. So after correction of H and T's, I would again check rhythm. It is again showing ventricular tachycardia without pulse. So again, I would repeat third dose of defibrillator shock, 4 joules per kilo again. After giving shock, I would resume CPR and also keep on repeating adrenaline every 3 to 5 minutes. So I have given, now I'll check the rhythm again. I think this is showing sinus rhythm. So I'll checking the pulse. The pulses have returned, and this is return of spontaneous circulation. So I would update the family and communicate with parents. So we have already seen the treatable or correctable causes of cardiac arrest, preventable H and T's. Next slide. Yeah. So essence to remember, I think this was also again covered in last case, but 2 points I would focus: to give 100% oxygen while giving high quality CPR, and prepare for advanced airway if you have allocated roles to team members, because prolonged chest compressions or cardiac massage is better done with endotracheal intubation rather than bag and mask ventilation. Next slide. So to summarize this case, pulseless ventricular tachycardia presents as cardiac arrest and is definitely treatable with DC shock. We can easily identify VTAC on cardiac monitor as wide complex fast rhythm. Shock is the mainstay of treatment, along with treatment of those correctable causes, H and T's, like electrolyte imbalance and acidosis. Thank you. So now I would like to invite Dr. Lakshmi and Dr. Rohini for next case.
Dr. Rohini, are you here?
Yes, ma'am. Just a minute.
Yes.
I'm having a power issue. Yeah.
Okay. I cannot see you, Rohini. Your video is not on.
Yes, ma'am. I'll just switch it on.
Yeah, you're seen. Yes. Should we start?
Yes, ma'am.
Yes.
Okay. So, Dr. Rohini, this is a 1-year-old who was brought out from the pond after drowning, and her mother has brought her to the emergency room. Could you please assess the child and look into it?
Oh, yes, ma'am. I shall immediately take care of the child. I am in the ER with this child. Let me do my initial assessment first. I'll check her responsiveness. Hey, are you okay? She seems unresponsive. I'm checking her breathing. She is not breathing, and her color is also mottled. So I would like to check her pulse first. Her pulse is absent. That means child needs immediate CPR, and I'll proceed with the IAP BLS algorithm. I will call for help, and I'll start high quality CPR with chest compressions. As soon as the help arrives, I will delegate the chest compressions to another provider and instruct to start bag and mask ventilation with 100% oxygen. I will ask sister to attach monitors and start on the defibrillator. As soon as the defibrillator gets ready, I will check the rhythm.
What is this rhythm?
This is asystole. So, which is a non-shockable rhythm. So, I will ask my team members to immediately resume the CPR for 2 minutes, and I will ask another team member to establish an IV access so that we can give epinephrine. I'll ask my sister to prepare a epinephrine of 1 in 10,000 solution by diluting 1 ml of epinephrine with 9 ml of normal saline. And according to length-based assessment, the child seems to be around 10 kg. So I would like to give 0.01 milligram per kilo of epinephrine, that comes around 1 ml of 1 in 10,000 solution of epinephrine, to be followed by normal saline flush, 5 ml of normal saline flush, and this is to be repeated every 3 to 5 minutes. After every 2 minutes, I would like to check the rhythm, and meanwhile, I'll assess the 6 H's and 5 T's as a reversible causes of arrest. So these are hypoxia, hypovolemia, hyperacidemia, hypoglycemia, hypothermia, and hypo or hyperkalemia. Now here I will remind my sister to do a blood sugar check.
That is, I think, 45 at this time.
Okay, then I would like to give 10% dextrose in a dose of 5 ml per kilo. That comes around 50 ml of 10% dextrose, to be followed by 200 ml of normal saline bolus. And again check the blood sugar after half an hour. I would like to check the rhythm again at the end of 2 minutes.
What is this rhythm?
Okay, I would like to check the pulse.
The pulse is present.
That means the return of spontaneous circulation is there. So now I am checking her breathing. There are no spontaneous efforts. So I would like to intubate this child and to provide a rescue ventilation at the rate of around 12 to 20 minutes, 20 per minute, and prepare to shift her to PICU for post-arrest care.
Excellent, Dr. Rohini. Your rapid assessment has helped you recognize the child to be in cardiac arrest. Using connecting a monitor has helped us identify the rhythm as an asystole. And we know that asystole is a non-shockable rhythm, and hence connection of a monitor in a patient of arrest is extremely important. And also you have identified reversible cause of asystole of arrest, and you have treated it, and hence the child has been revived. Excellent work, Dr. Rohini. I now invite Dr. Somshekhar and Dr. Sandeep to take us to the next case scenario.
Thank you, Dr. Lakshmi. We will go ahead to the next case, which is a 2-year-old who has been struck with a vehicle and has been brought to the emergency room. Dr. Sandeep, can you take charge of this case and discuss this case right away? Dr. Sandeep, is that?
Yes, sir. I'm audible.
Yeah, you're audible. Go ahead. Please, please go ahead and manage this case.
Yes, sir. I'll repeat again. This is a unresponsive 2-year child who is brought to the ER. Sir, so first I will check for responsiveness. I will alert the people around me. I'll activate the emergency response system. I'll call for help. I'll attach O2 and monitors. And within 10 seconds, I'll try to check for the brachial and the radial pulse. If the pulse is less than 60 per minute with poor perfusion and unresponsiveness, I'll start CPR based on IP-BLS protocol with bag and mask and 100% oxygen at a rate of 30:2 as I'm alone till a help arrives, which might take some time. And when the help arrives, I'll change over the roles, and he and me will be coordinating at 15:2 for 10 cycles. By meantime, I will assign roles of IV IO access. I will also prepare drugs and keep AED ready. Yes, sir.
Now you would have AED on screen. Can you look at the ECG pattern which is there? I would remind you that there is no pulse as the screen shows.
So this is an organized rhythm, but there is no pulse. So this is a pulseless electrical activity. Now, pulseless electrical activity is treated, it is a non-shockable rhythm. So I will continue CPR for 2 minutes, give epinephrine, which has already been told previously. I'll prepare epinephrine 1 milligram in 10 ml. I'll dilute it and then give 0.1 ml per kg, which will roughly come out to be 1 ml for a 10 kg child. Give it and push a bolus of around 5 ml NS and start CPR at the ratio of 15:2 as the second assistant is available with me. I have accessed the IV. I'll still sample for sugar, ABG, and electrolytes. Yes, sir.
Yeah. If you looked at it now, can you have the next slide? The patient is still not improving. So what do we do now?
Yes, sir. So I'll have to consider other alternatives why the patient has not improved. So these are 6H and 4Ts. So I will try to see for hypoxia. Hypoxia is ruled out of equation because I'm already ventilating with 100% O2. Hypovolemia is a possibility. ABG might have come by this time if it shows whether acidosis is there. Hypoglycemia, a point of care BSL has been done. There is no hypothermia, and hypokalemia might be visible on ABG, which is provided at that point of time. Yes, sir. I've checked for 6H.
Yeah, so 6 is now. What we still did another ECG, the rhythm, and it still shows a
Again,
normal QRS and no pulse. So
so no
what
pulse
other
is-
possibilities can be there?
So then I have to move towards 4T. So
Yeah.
there is a history of a vehicular accident. So toxin, thromboembolism, and tamponade with pneumothorax should be considered. This is most likely to be.
There is some injury on the chest. Injury on the
Yes,
chest marks are there.
yes. So on exposure, I'm getting injury on the chest. This looks
and
like
since
a,
this was brought to
yes. So
this was brought to the emergency. There is
So
some
this looks more like a
possibility of
tamponade, and we will do a pericardiocentesis for this child. So what has happened after the procedure?
After tamponade was removed, or the tamponade was relieved by pericardiocentesis, you can see here that there is a rhythm strip which is there, and you have a heart rate of 129. And more importantly, next please, you can see that the pulses are already there. So this patient's pulses are have come back. So you have treated one of the causes of pulses electrical activity. So I think that is a good way that you have managed the child. So one of the important things that you remember is when you see a child who is listless and not responding, and you don't get a heart rate and the baby is not breathing, you have to begin giving resuscitation immediately. So in this case, Dr. Sandeep began CPR and gave bag and mask ventilation using 100% oxygen and started IV and IO access. As we saw the rhythm was sinus, but there was no pulse. So this is basically a rhythm which cannot be shocked, unlike the earlier ones that we might have seen. So in this case, we would just go ahead and look for the give CPR, give epinephrine as was mentioned, and repeat the cycle and search for the various causes which might lead to which might lead to PEA. So this can happen in drowning. One of the causes could be drowning, as you saw in this patient, tamponade, pneumothorax, and this is not uncommon. We have seen such patients, and they have improved upon noticing the HSNTs. So it's important to ensure that this is followed. Putting an advanced airway might be a good idea too, because you might have to ventilate these patients for a long period of time. So like asystole, pulses, electrical activity, we need to keep in mind. Just not look at the monitor, look at the patient, examine the patient. And there is always some underlying cause that we can manage. Very well managed, Dr. Sandeep. And we can proceed to the next case. In this case, I would call upon Dr. Akash and Dr. Sagar for managing the next case. Thank you very much. This we have discussed. Can we go ahead?
Yeah, good afternoon, everyone. Dr. Sagar, you are there?
Yes, yes. Okay.
Yeah, so Dr. Sagar, you have been called to take care of this child. This is a 10-year-old child who was wheeled out of MRI room, and after an MRI, he was in observation, and suddenly the nurse calls me saying that the desaturation alarm is going off and the child is desaturating. So you are called to attend this child.
Okay, thank you. Yes, sir. I will take care of the child immediately. Now, first will be my initial impression. In initial impression, I will see about the consciousness of the child, and the child looks to be lethargic. In the breathing, the child has got a shallow breathing, and the color of the child, it looks to be mottled and the cyanose. So by my initial impression, all the parameters are in the yellow zone. So this child immediately required care. Means I will gather my all team members. I will attach the monitor to the child, see the rhythm. I will start with oxygen, 100% oxygen with NRM. I will check the blood sugar. I will ask my team member to check a blood sugar level, put an IV cannula. If needed, IO. If IV was not possible, and I will continue with the detailed assessment of the child. Next slide, please.
Okay, very
so
good. Next slide.
I will first do a primary assessment of the airway. I will see the airway, what is the problem in the airway, whether it is maintainable airway or non-maintainable airway. I found that there is a lots of secretion were present because the child has got a tongue tongue was back because he was little bit of not fully conscious, and then lots of stridor was also coming out. So at that point of time, I will ask my team member to do the suction and do a head tilt chain lift maneuver to just keep open the airway. And after doing the procedure, I found that the airway opened up and child started breathing. After the airway will come to the B, that is the breathing, and I found that respiratory rate was found to be slow.
10.
It was a 10 per minute.
Yeah.
Respiratory effort were decreased. I will also like to see the chest wall expansion of the child, and the chest wall expansion has also decreased. I auscultated the child and the air entry was absent on the both the side. I also checked the pulse oximeter at that point of time, and the pulse oximeter found to be less than 90% on the oxygen. So all these parameters point out that all are in the red zone. So immediately this is acute emergency and child need a bag and mask ventilation. I will ask my team member to start a bag and mask ventilation, and I will continue my assessment of the child. So I will do the circulatory assessment, but the other person will continue the bag and mask ventilation. While doing the circulatory assessment, the heart rate, I found that, how was the heart rate? Heart rate was less than 60 per minute. 60 is very important point. More than 60 always need a cardiac massage. So heart rate was less than 60 per minute. The rhythm was found to be a normal QRS complex rhythm. The pulse, central and peripheral pulses found to be decrease in the volume, and the capillary refill time was more than 2 seconds. So I found that this child has got a low capillary refill. So it was a little bit of the low perfusion state, but very important. I will first start with the IPPV to this child, and still the perfusion is poor. I will consider of giving the normal saline bolus to this child, but I will continue the assessment of the child further ahead. Next slide, please.
Next.
So on the skin color, I found that the child was a cyanose and the skin temperature was cool. And systolic blood pressure, what's blood pressure? The blood pressure was less than 5th centile, and it was 80 by 36. So this child has found to be in hypotensive. But review the perfusion after establishing the IPPV. Sometimes the color improve and heart rate also improve after normal saline bolus if the pulse volume is low and the BP is not improving. Next slide, please. So after continuing the bag and mask ventilation, I found that after 2 minutes, the child blood pressure has increased up to 96 by 60, heart rate has come up to the 80. So I conclude that the child is little bit stabilizing, and then I will go ahead with the D and the E assessment. GCS on the D, the GCS, our ABPO system found to be 8 to 12, and the child was response to the pain. And the blood sugar level, I think it was initially done and was found to be normal. And the pupil was equally reacting to the light. So next slide, please. So also along with the D, I will check the temperature of the child, and the temperature found to be normal, and the deformity, swelling, and injury were normal. So after finishing the A, B, C, D, E approach, next slide, please. I will come to the conclusion that this child, after the MRI investigation, found to be in respiratory failure, which was picked up early in a systematic way and was given a bag and mask ventilation. During the assessment, also found that he was hypotensive, but this hypotension was improved with the bag and mask ventilation, not required in the fluid boluses. So ultimately, the conclusion was in cardiopulmonary failure, which was responded well to the bag and mask ventilation.
Very good, Dr. Sagar. You took you managed this child very well. Next, please. Next slide, please. So I think summary of this case is that we need to realize that this child was basically having bradycardia, and we need to remember that the commonest cause of bradycardia is actually hypoxia. Very slow as well as very fast heart rate will result in poor cardiac output. So bradycardia can also result in poor cardiac output and thereby low perfusion, poor perfusion. So as a part of cardiopulmonary failure, because this was bradycardia and so respiratory failure along with hypotensive shock, so it qualified for cardiopulmonary failure. But still, Sagar started with immediate ventilation with 100% oxygen, and reassess the child after this. If in spite of starting good ventilation, if the child's heart rate would have been low, less than 60, and the perfusion would have been bad, then chest compression was definitely needed. If the heart rate is more than 60, the chest compression is not needed. And then based on the pulse and circulatory status, you would decide whether bolus is required or not. Untreated cardiopulmonary failure can deteriorate to cardiac arrest and death within minutes. Other causes, we list out the causes of bradycardia. We say that from number 1 to number 5, it's all hypoxia, hypoxia, hypoxia. After that, acidosis, blocks, myocarditis, cardiac surgeries, congenital heart disease, and all these causes should be considered if, in spite of correcting ventilation and circulation, the bradycardia persists. So that's all for case 13. For the next case, I call upon, invite Dr. Manish Jain and Dr. Ashish Lothe to take care of the case 14. Thank you.
Good afternoon once again. Dr. Ashish, are you there?
Yes, sir.
Yeah.
I am there. Yes, sir.
Yeah. So you have been called to emergency room to manage a child who's 10 months old child and was presented with history of poor feeding and lethargy. And mother says that the child is not looking well. So kindly attend to this child.
Yes, sir. I'll immediately attend to this child. I am in emergency room with this child. So let me do my initial assessment first. That is ABC or CBC. He appears lethargic to me. He is breathing fast and he looks pale to me. All these three parameters fall in yellow zone. So this child needs acute care. So I'll gather my team, allocate roles and responsibilities, attach monitors, defibrillator, power them on, start 100% oxygen using non-rebreathing mask, establish vascular access, preferably IV, otherwise IO, and check blood sugar. Meanwhile, I'll proceed with my primary assessment.
Yeah, blood sugar is 100.
Blood sugar is 100, yes, sir, normal. So now I am looking at the airway. There are no secretions, no sounds while breathing. Chest rise is bilaterally symmetrical. So I can categorize airway as open and clear. Next, I will move on to next section, breathing of primary assessment. Child is breathing fast. So let me count his breathing rate. It is 58 per minute. So I'm looking at accessory muscles of respiration. There is no increased work of breathing. Chest wall expansion is good. Let me auscultate for air entry. I can't see slides. So on auscultation, air entry is equal and there are no adventitious sounds. Coming to pulse oximetry, the monitors are already in place by now. So SpO2 or saturation is 91 to 92%. So this completes the list of parameters to be assessed for airway and breathing. So child is breathing fast and SpO2 is 91 to 92%. So I'll proceed for assessment of circulation, the next thing in my primary assessment. So can I see cardiac monitor to check heart rate?
It is 280 beats per minute.
Okay, so the 280 beats per minute heart rate is very fast for his age. Can I about the rhythm?
Yeah, QRS complexes are narrow and there are no P waves.
And about beat to beat variation?
There's no beat to beat variation.
So this indicates it is supraventricular tachycardia. Next, I'll check for child's pulses. Central pulses are palpable, but peripheral pulses are poor volume. I'll now check for capillary refill time. This is 4 seconds.
4 seconds.
Yeah. So this indicates child has SVT with poor perfusion. I'll quickly ask my team members to arrange for urgent synchronized cardioversion. While it is being arranged, I'll try vagal maneuver. So I'll put ice packs into rubber gloves to be kept on upper part of face, sparing nose and mouth for around 15 to 20 seconds. Meanwhile, I'll complete rest of the circulatory assessment. Now I am looking at skin color and skin temperature. With normal ambient environmental temperature, extremities are cold, skin is pale. Now I'll check child's blood pressure. So blood pressure is 72/52, which is normal, more than 5th centile for this age. So this child has a cardiogenic shock with poor perfusion, probably due to SVT. IV line has already been established, so I'll quickly arrange for IV adenosine. Meanwhile, after vagal maneuver, I'll also reassess my circulation. So while the IV assembly of adenosine is being arranged, I'll complete the checklist for disability and exposure. So child is pain responsive on AVPU scale. Let me check his pupils. Pupils are bilaterally equal, reacting to light. Coming to exposure, child's temperature is 98°F, and I see no rashes, swellings, deformities, or injuries on exposure. So upon completion of primary assessment, this child looks to have circulatory insufficiency with compensated shock, as child's blood pressure was normal. Also respiratory insufficiency with respiratory distress. So the child appears to have a narrow complex tachyarrhythmia, SVT, resulting in poor perfusion and compensatory tachypnea. So with IV line is ready, if it was ready, I'll proceed for urgent IV adenosine. If IV line wasn't available or was difficult, I would arrange for urgent cardioversion. So can we play the video?
To give adenosine by a 2-syringe technique. This child is a 10 kg child, so we'll be giving 1 mg of adenosine according to 0.1 mg per kg, and we have placed the IV cannula as close as possible to the heart. Adenosine, please, followed by flush.
Yeah. So this technique is very crucial of giving adenosine. So after adenosine, I'll check the rhythm again. The rhythm appears normal sinus rhythm. So the rhythm has been reverted back. Now I'll communicate with parents and family about this child.
Thank you, Dr. Ashish, for excellently managing this case. And you perfectly followed the checklist, and probably that helped you in managing this case very well. Now remember,
thank you, sir.
This case, very slow or very fast heart rate results in poor cardiac output. And SVT is concerned, it is sudden onset, without other explanation for fast heartbeats. Fast heartbeat or heart rate above 220 in infants and 180 in children, as mentioned in your checklist. It has narrow QRS complexes, no beat to beat variation, and P waves are absent or abnormal. And there can be sudden cessation of abnormal rhythm on treatment. Thank you. And now I invite Dr. Mandar Deshpande to give the next talk.
Hello.
Yeah, Dr. Mandar.
Yeah, I am there. Yeah.
Sir, you are sharing your screen, right?
Yeah, if you are.
Yeah, I'll stop sharing my screen so that you can share yours.
Thank you. Am I audible?
Yes, sir, you are audible.
And my slides visible?
Yes, your slides are visible.
Okay. Thank you, Dr. Now, this is lights, camera, action, and COVID everywhere. And IAP ALS recommendations have changed or have made some changes during this COVID pandemic. All over the world, they have changed. IAP ALS recommendations, I will go through them very quickly. Now, it is very important to know that we all have these equipments ready on our crash cart, as we all are aware of all this. But what are the special things which are required? And that is definitely a full 4 set of PPE, 5 additional N95 masks and gloves, and a CPR board, face shield and a surgical mask for victim, aerosol box, which is required to cover the face of the victim in case if you require advanced airway, laryngeal mask airway. This is a very important point to note, that laryngeal mask airway is an important rescue airway in such situations. We all know that intubation, bag and mask ventilation, even CPR is an aerosol generation procedure. So using a laryngeal mask airway will help us to prevent the aerosol generation. Though it is a aerosol generation procedure, it doesn't take too much of time if you are quite well experienced. And they are available in all the sizes, right from newborn to adult. Now, the most important thing here will be HME filter. And not only HME filter, here we require a HME filter with a viral and a bacterial filter. So the normal HME filter has a humidification and moisture exchanger. We just exchanges the moisture and the humidification of the patient, but it doesn't prevent the virus to go inside, virus or the bacteria to go in the circuit or come out of the through the expiratory limb, causing aerosol generation to the healthcare provider. So it is very important to have this. A bag and valve device will be very handy, and an inline suction, a closed loop suction is very important. We see how it works and why it is important. ETCO2 monitor is also desirable. The most important thing here one should note is that the scene should be safe. Once we are safe, then everything is safe. There is no emergency in a pandemic. That is always, that is a tagline. First, you get yourself to have a safe scene, and then only you can go ahead with the resuscitation of the child. So first come is a P, then come is a CAB sequence. P is for person, personal protective equipment. So PPE, double gloves, N95 masks, eye gear, full PP is required. Surgical mask is okay for out of hospital cardiac arrest. Pending laboratory reports manage each and every case requiring resuscitation as a potentially COVID-19 case. So if the child, you have seen the morning OPD for something and comes with a convulsion in the evening and requires resuscitation, always consider this as a potentially COVID-19 case and treat it accordingly. Try to shield the patient's mouth and nose with an aerosol box or a surgical drape or even a surgical mask before starting chest compressions, or if the airway is not secure. Do not give mouth-to-mouth ventilation or mouth-to-mask ventilation in this scenario. Use only compressions, that is only CPR until the victim's airway is secured. So these are the few recommendation changes which are very important. Ensure that the airway is safe for provider. It's very important to have a personal protection first, and then CAB sequence will be followed up. Compression only CPR till the airway is secured. So only compression, that is chest compressions without giving bag and mask ventilation till the airway is secured is the dictum. Now, once you see that how to take care of the airway. So securing the airway is very important. Now here, the most important thing I would like to highlight is a laryngeal mask airway is the best. It generates very less aerosols. It is very easy to put, and it is available in all the sizes from newborn to adult. Just glide it over the patient's palate until you get a resistance where it enters, and try to give a bag and laryngeal mask airway ventilation, and you will be able to get a good chest rise. If intubation, insertion of LMA is delayed, use bag and mask ventilation, but take care that you should have a viral filter and a viral and bacterial filter which is attached along with the HME filter in between the bag, in between the mask and the bag. I'll show this, that this type of HME filter, which is a normal filter, do not buy these type of simple HME filters. They are not useful in present scenario. What we need is a HME filter with the bacterial and viral filters, and the humidification gets plotted over there, and as well as the bacterial and virus filters help us to prevent the virus giving rise to a lot of aerosols in present scenario, preventing the healthcare provider infection. Now, HME with a bacterial and viral filter needs to be changed every 48 hours, and it is not very costly also. So do not buy these simple HME filters. Buy a filter which has a bacterial and a viral filter inside it. So this is a typical bacterial and viral filter. I have taken a snap and posted over here. Where to put these filters? So most important is in between the mask and the bag. You will have to put this filter when you are giving a bag and mask ventilation, so that it prevents the aerosol from coming out and into the environment around the patient, causing infection to your healthcare providers. In a ventilated child, you have to use two filters, one at the patient end after the Y piece, after you connect it to the ET tube and before you connect it to the ventilated tubings, and one at the expiratory limb, because all what is given in the expiratory limb from the patient will be coming out. So here one filter will be required. So two filters in a ventilated patient. Similarly, use only cuff tubes. Cuff tubes are essential in this scenario because uncuffed tubes generate a lot of leak also. And when you put a tube, the most experienced person in your team should put a secure endotracheal tube. Secondly, it should be clamped before you secure a tube, because when you try to put a tube inside, there is a possibility that during exhalation, a lot of secretions or a lot of aerosols will be generated. Clamp the tube when you are putting, and during the AT suction also, patient may cough out onto you. So take proper precautions while suctioning the patient who is ventilated. Securing the patient's airway, it is important that once you put a endotracheal tube and you secure the airway with endotracheal tube of proper size and which is a cuff tube, and you check the airway and you apply the ventilator and you start ventilating the child with 2 filters, one at the Y end of the patient, one at the expiratory limb of the patient. The most important here is the inline suction. Now look at this. This is a closed suction device. So it prevents handling, it prevents infection, it prevents the aerosols to come out, it prevents taking the patient out of the ventilator. There is a chance that during the ventilation, that if you take the patient out of ventilator, the aerosols can come out with the inspiration and exhalation of the patient. So when the patient is not ventilated, using a non-invasive ventilator, you should use this type of non-vented mask for a BiPAP machine, bi-level PAP machine, and a ventilatory machine. And if you have vented mask over here for a non-invasive ventilation, they are not recommended interfaces in present scenario, because they will not prevent aerosols from coming, aerosol generation procedures. Now, while intubation and while other procedures, it is very important that you should have a restrictive team composition. You should have only 3 people inside. Initially, we used to have 5 team members for resuscitation. Now it is a rule that you should have at least 3 people, not more than 3 people, because we need to prevent the infection to other healthcare providers if at all it is a COVID positive case. Similarly, it is also important that the compressor and the person who is giving airway can interchange in between them, and 1 person for defibrillator. The role for person who is at a end of team leader and from the outside. Anyone of COVID about should not be
Mandar, are you there? Can you continue? I have shared the screen. Or Akash, can you take over?
Okay, I think I can start and continue till Mandar takes.
Yeah, you can start. You can start. I will move the slides.
Yeah. Members exposed to resuscitators that we have discussed would be airway, compressor, and 1 person taking care of both defibrillation and medication. And outside the room or at a slightly distance would be people who are preparing drugs or people who are recording or discussing with the relatives or counseling the relatives. One thing that we must remember is anyone at risk, that is above 60 years of age or having comorbidities for severe COVID-19 infection, must not participate. And especially presence of family members should be discouraged during the resuscitation. Next, please. Yeah, so things that we need to remember while placing the tracheal tube or intubation is that in COVID situation, it is advisable not to go ahead with bag and mask ventilation, and because that is again creating aerosol and exposing a lot of people to that. So intubate using a video laryngoscope that Mandar has already discussed. Place an aerosol box or a locally made similar barrier device so that the aerosol is not coming in contact with the team members and it is limited. Ensure that chest compressions are stopped while intubating. Attach a viral filter, it's already been discussed. And once the ET tube is inserted, then that needs to be attached. Inflate the cuff immediately. ET tube has to be a cuffed ET tube as far as possible, and the cuff needs to be inflated immediately. Avoid auscultation and use EtCO2 detector for ET tube placement. Next, please. Yeah, so the same thing has been depicted here. The original algorithm and the COVID related changes that have been made in the algorithm. So ensure that airway is safe for the provider. Compression only CPR till airway is secure. These are two important things here. Next, please. So what are the modifications in the resuscitation algorithm? Next, please. So first, an important thing is compression only CPR with airway shield, secure airway and use viral filter, bag mask, ventilation with viral filter and tight seal. Okay. Then as you can see here on the left hand side, on the right hand side, advanced airway if it has already not been achieved. And so whenever possible, the airway the intubation should be done instead of bag and mask ventilation. AED and defibrillator, preferably used AED. If defibrillator pads are available, then use them in place of conventional paddles. Consider, we have seen H's and T's. So 6H and 4T's we have seen. Consider a 7th H in case of COVID situation, COVID context, hypomagnesemia, because the QT prolonging drug combination of hydroxychloroquine plus azithromycin can especially cause cardiac arrhythmias in face of hypomagnesemia. So torsade de pointe or polymorphic ventricular tachycardia should be especially looked for. And if it is present, or even if it is not present, early in CPR management, consider magnesium sulfate if the fibrillation is not responding. Next, please. CPR can be given in prone position with an advanced airway in place when the patient cannot be placed supine. Attach to ventilator early and continue CPR without pause. Ventilate with a tidal volume of 6 ml per kg of body weight. This is wrong, 6 ml per kg it should be there. FiO2 of 100% and respiratory rate of 10 to 12 in adults and 12 to 20 per minute for children. Consider replacing manual chest compressions with mechanical CPR devices. Now, this may not be available in every setting. So if it is available, then it should be considered. Early use of vasoactive drugs should be considered instead of too much of aggressive fluid resuscitation, especially in patients with return of spontaneous circulation. And consider appropriateness of resuscitation or duration of CPR. So Mandar, I can see Mandar message. Please allow me to join through panelist link. Okay. So Dr. Mustafa or someone from IIP can please promote Mandar to panelist status. Till that time, I'll continue in the interest of time.
Okay.
Please advance the slide. So this we have seen the 6 H's and 6 T's stand there. One, hypomagnesemia is the extra H that we need to consider. Shock, it is the same. epinephrine same. So what are the modifications for COVID scenario? So addition of magnesium sulfate 25 to 50 milligram per kg IV infusion over 10 to 20 minutes. Of per kg, sometimes we forget what is the maximum adult dose. So we need to remember that the maximum adult dose is 2 gram. This might be especially important and relevant in cases of adolescents or obese children who are overweight. Next, please.
Akash, thank you for continuing the presentation. I don't know what happened.
Yeah.
Am I audible now?
Yes, you are audible.
Extremely sorry.
So summarize for us.
Yeah. So protect yourself first and don PPE. That is most important thing. PCAB, that is protection first. Then comes circulation, airway, and breathing. You should have a restrictive team approach where there will be at least not more than 3 people around while doing a resuscitation. The fourth and the fifth person, that is the leader of the team and the person who is noting down the things, should come away from the resuscitation scenario. The administrator of the drug administrator should be inside. Similarly, it is very important that person who is at a risk of COVID infection, more than 60 years of age, or any other problem should not be allowed to go for a resuscitation. And airway related procedures we already discussed. Do not bag and mask. It is a thing which can generate aerosols. So it is preferable to use a video laryngoscope or use a LMA. LMA will come very handy during this scenario. It is the best rescue device. It is available in all the sizes. Ensure chest compressions are stopped while intubating. You can give chest compressions, only chest compression CPR also, which is recommended when you are not able to secure the airway. Attach a viral filter or filter with a viral and a bacterial capacity to filter. Once the AT tube is inserted, always use cuff tubes and inflate the cuff immediately. Avoid auscultation and use EtCO2 for AT tube displacement. And for suctioning, it is very important that you should use closed circuit system. Next, please. Next slide, please. Yeah. So preferably use AED. If defibrillator pads are available, use pads in both conventional paddles. Consider the 7th H, that is hypomagnesemia, as a potentially reversible cause of cardiac arrest, because here it is very important to note that if you are able to judge the potentially reversible causes of cardiac arrest, then the resuscitation is not required, and again the aerosol generation procedure and the healthcare infection rate will also decrease. CPR can be given in prone position with an advanced airway in place. Attach a ventilator early and continue CPR without a pause. Early use of vasoactive drugs instead of giving aggressive fluid boluses till the patient gets a ROSC, and consider appropriateness of resuscitation and duration of CPR whenever required. Thank you. Thank you very much. I'm extremely sorry for the technical glitch which happened, and thank you, Akash, for continuing the presentation. You can submit your feedback forms and post-test. They have already circulated on WhatsApp, and submission of both the forms is essential for certification. Okay. Now may I request Dr. Somshekhar for his presentation on breaking the bad news.
Thank you, Dr. Mandar. It's nice to see a good collaboration between all instructors to ensure that we don't leave a lecture in between. So thank you, Akash and Mandar, for ensuring that we continue on time. So I hope and I'm hoping that everyone has seen the video that was circulated to everyone on this subject, and just think about the video that you have seen, and I'm sure when you have seen the video you must have noted a few points. So just looking at a few do's when we do the when you've seen the video, what we should be doing currently. One is we should always introduce yourself and identify yourself as identify the primary caregivers, that is introduce yourself as the doctor caring for the child, and if it is a team, then introduce the other team members too, and then talk to the primary caregivers. The communication should be always clear and continued. So because resuscitation can go on for a long period of time, like it could go on for half an hour, 1.5 hours in the emergency area, it's important to give continuous messages to the parents so that they understand what is being done. And we should avoid being rude. We should be kind and share the correct information with good empathy towards the family. Depending upon the situation, you can either keep the parents in the room for resuscitation or they may want to be placed in a different room which is close by. So another trained member can escort the family to a quiet area close by. So all emergency rooms preferably should have a counseling room close by where parents can sit when resuscitation is going on. Whenever you're talking to the parents, maintain eye contact. So ensure that you're communicating to them directly. Very importantly, in many busy hospitals, there might be 2 or 3 children who are receiving resuscitation. Hence, it is important to identify the primary caregivers and talk to them with their child's name. You don't want to be counseling the wrong parents about the wrong child. So this is very important, especially in busy areas. Use plain language. So say that the child is very sick or unlikely to survive, or if the child has died, then say dead. Don't use complicated terms that we are coding him or he is undergoing resuscitation or some ventilation which they will not understand. Very important to ensure that we give a realistic prognosis to the parents. What is the likelihood of him surviving, or what is likely to happen, or is there, so don't give false hopes कि सब कुछ ठीक हो जाएगा, चिंता मत करो. That is one of the last things that you would want to say, especially if the child is sick. If possible, allow the parents to be the child during the dying process if they wish to. It is quite useful in the long run because the process of grief involves a lot of stages, and ensuring that the child is there with them and they're there when the child is dying can often shorten this grief process and improve the grief process. Be a good listener. There are often questions that they ask, and no question is stupid. So make sure that you listen to them, talk to them, and be patient with them. Many times patients want to know, the parents want to know whether everything was done so that nothing was missed out when trying to resuscitate the child. And this should be mentioned in no clear terms. So it should be very clear. Many times parents at the last minute want to know whether shifting the patient at this point might be useful or not. So you have to be very clear that the patient is very sick and it is difficult to shift. So you have to be quite clear and open about what is being done to the child. Remain with the family for a while. So you could be busy, you might be required during resuscitation, but do spend some time. And when you are with the parents, don't try to appear busy, like looking at the phone, trying to look at other doctors, or appearing as if you really don't want to be there with the parents. So this is something which you should try and avoid. If many times parents can be angry, and you should understand, and you should not get angry because they are angry, because you might be thinking that you're doing everything for the child, a lot of trouble has gone, or a lot of people have come and resuscitated the child. You are not happy that the patient is not surviving, or the patient is not likely to survive. And on top of it, if the parents are angry with you, there's no point in getting angry with them. So you should understand that anger is part of the grief process, and violent reactions can happen. So you should be definitely not be showing emotion when anger is directed at you. So be quiet and be responsive. Especially in Indian situations, as we have seen in various videos, it is impossible. Suppose there can be a violent reaction, make sure that you have an area from where you can get out in case your life is a threat. So it's important that this also be taken care of. It's better to have some hospital staff help them with making phone calls. And this is important because if a child has died, some relative is there, they need somebody to come, the child has to be kept in some place. A death certificate is required, a hearse man is required, a lot of other things that are needed when a child dies. And it is important to have a social worker preferably who kind of helps the family with this particular process. Okay. If there is violent crowd behavior, very important to ensure that you have been communicating with the family right from the beginning. Okay. Sometimes what happens, you don't communicate with the family, and you tell them after everything is over that the child has died, and then it can be very problematic. So if you communicate on a regular basis and keep a continuing communication with the family, it is useful. I recently spoke to someone who's returned back from abroad, and what he told me, he's practicing in Pune. He told me that the only thing that is changed as far as medical knowledge is concerned is the way he behaves or counsels parents. And the way in which counseling is done is very important. May it be a regular counseling for patients in the wards, or in a situation like this when a child is likely to die under your care. If parents want to seek a second opinion, it is actually most doctors ask them that you should, and don't say कि अभी कोई फायदा होने वाला नहीं. So don't ever use those kind of words. They also may not know who the specialist might be that they want to seek an opinion, so you could give them options. Preferably somebody senior in your area who is well known, and it is quite useful. There are many experiences that the ALS instructors have shared where they have called their seniors in the same town, and seniors are always ready to help come down and explain to the parents that the child was serious, and all that could be done was done. So asking a senior to help is a very good strategy in this case if this is happening. Always record the main points of communications and let the staff take a realistic signature of it. In today's time, a lot of people use a camera to record counseling, and that is also a good idea. How to deal with a violent crowd behavior is, again, you have to understand the process of grief. Anger is one part of the process of grief, and that can, if it goes on to a lot of people, then one can have problems. So make sure that you keep your ego down. Never ever shout. क्योंकि जंग के बाद वापस टेबल पे आना ही पड़ेगा. So there's no point in fighting with anybody. So remember that be quiet, be responsive, and discuss with them. If you do perceive that there might be some violent reaction despite all this, it is important to ensure that there is some kind of protocol in your area where you kind of call the management, call the police, or call the security in the hospital. So some kind of process can be initiated to ensure that you are not at risk of harm because of a violent crowd. So having this protocol is useful. I think in small towns in India, because of violent crowd behavior, they have a WhatsApp group of doctors, and they ensure that all of them can come together if something goes wrong. This does help and has helped in previous times. What don't do? As I said earlier, don't give false hope. Don't look very busy when you're with the parents, like taking phone calls and making phone calls, anything like that. One very important thing that one learns, especially if you're a resident, is that don't talk about saying that ki, gone to a better place, gone to God or such things, because you don't know what the reaction of the parents can be. It's preferable to use the word died or dead. Very importantly, preferably the notice or the information that the child has died is best made by the senior most person in that area rather than a junior most person. So it is important. It's good to have a junior along with you so that they learn from you, but it is important that the senior person makes the announcement. Don't try to speak philosophically. Don't say that you have other children or you are young and you could have more children, and never ever say such things, and just keep it to what the patient is having. Many times some of these deaths could have happened because the family might have actually brought the patient late, or the patient might have had an accident because the parents are not looking. And so when the parents come, they already are having a guilt feeling, and having a guilt is part of the grief process. One should not try and compound that process by saying further wrong things, that you brought your child late, or you didn't take care of your child. If you had come earlier, you could have brought better. And if the patient is referred, never ever say that that doctor referred late, or that doctor did not treat properly, because today you're saying about that doctor, somebody could be saying about you later on. So it's something which is not at all good. And once a child is dead, they will not differentiate between that doctor and you. So it's best not to say such things. And of course, never appear in haste, as we said earlier. We should all understand that while we all want the patients that who come to us should survive fully and completely and have a good life after they take treatment with you, death is something which is going to happen often. In fact, the under 5 age is one of the ages when the maximum deaths occur. You are most likely to die in your first 5 years of life rather than later on. So it's something which we see very commonly, pediatricians, and you should be able to accept that deaths can occur to children under your care. It's best to be prepared for it, understand it, and have a matter of fact approach towards it. Be legally correct, be appropriate, it's okay to cry a little bit or to shed a tear if you have known the patient for a long period of time. So empathy is very important, and this is something which we should practice. In our hospital, in my hospital in Gujarat, Karamsad, we have something called as a Code Krishna, which we do for all deaths, not for children, all deaths. You could Google it, Code Krishna, and look at that paper. I think that's it from me. Thank you, and over to you, Akash. Akash?
Afternoon, good evening, everyone. We are at the fag end of the course, and I'm sure you 4 hours we saw the IPLS tool. We saw the assessment part, how to assess a child. Then we saw how to apply the ALS tool or the checklist in 14 different cases. The whole spectrum of pediatric illness we covered. We also saw how simple it was, right? And I'm sure that at the end of this course, you would agree with me that anyone who has some knowledge of vitals or some knowledge, so someone like a paramedic or nurses can definitely be trained in this ALS tool and the assessment through ALS. I'm sure you would appreciate how quick it is. It doesn't take too much of time, doesn't rely on too many investigation. And I'm sure you would also appreciate how effective and accurate it was. Basically because it focused on the physiologic derangement rather than chasing the etiological diagnosis. So with that, I thank all instructors. So first of all, I thank IIP Nagpur, the patron of IIP Nagpur, Dr. Uday Bodhankar sir, President Dr. Shobda Khirwadkar madam, Secretary Dr. Mustafa Ali, and the whole IT support team for creating this platform where we could conduct this wonderful course. I fall short of my words when I want to thank all the creators and contributors of this wonderful module, and all the faculty who volunteered 4 hours, not only 4 hours, but so many days of discussions, etc., of their busy schedule for this module. So thank you, Dr. A.K. Sharma, Dr. Mandar Deshpande, Dr. Manish Doshi, Dr. Manish Jain, Dr. Meenakshi Girish, Dr. Somshekar Nimbalkar, Dr. Anjali Otiv, Dr. Kiran Vaswani, Dr. Nivedita Patil, Dr. Geeta Bhatt, Dr. Lakshmi Shobhawat, Dr. Sagar Lad, Dr. Sandeep Golla, Dr. Ashish Lothe, Dr. Rohini Ingole, Dr. Swapnali Bansode. Thank you so much for contributing to this course of today. And special mention for the projectionist, Dr. Nivedita Patil. It is very, very difficult for 4 hours to sit in front of a computer and keep on clicking, coordinating with the speaker who is speaking. So thank you so much, Dr. Nivedita. And thank you, Dr. Mandar and Manish Jain, for agreeing to be the backup projectionist in case of any technical glitch. Last but not the least, thanks to all the wonderful participants who participated today and made this course a success. Before I go on to some housekeeping or some certification related instructions, any instructor wants to say anything? Anyone wants to give any feedback, any comments?
Yeah. So I would like to say that this course is quite well designed. This is, I think, my 3rd or 4th course, and it has been very interesting. The way in which instructors are kind of managing the cases and ensuring that the point that needs to be learned is put forward explicitly is well done. And it is important that we can continue this for, relatively on a regular basis. And we could probably do this courses for smaller batches of 30 or 34. Like we could organize these courses for smaller number of people, and 6 to 8 instructors can do it on a regular basis. So maybe once in a month, it would be helpful for all the pediatricians that need to be groomed in this kind of teaching, because we are not having the physical courses as of now, at least. Thank you.
Yeah, thank you, Dr. Somshekar sir. Thank you, Dr. Akash. Thank you, Nagpur IIP, and thank you all esteemed IIP ALS faculty for today's course. It was a great gathering, and in spite of technical glitches here and there, we could able to provide what we wanted to provide. The most important thing here I would like to highlight is that always try to use this ALS-MAP tool in your day-to-day practice. in your emergency room, in your casualty, in your nursing homes. So that will decrease the mortality and the morbidity in the patients. That is for sure. The second important thing, to get a proper certificate or successful certificate, Dr. Akash has already mentioned that you need to submit the post-test. Have you disclosed the post-test link, Akash?
No, not yet.
You will get a post-test link.
It will be circulated on the WhatsApp group after the course ends.
Yeah. So once you submit back the post-test answers, your pre-test, post-test answers and your feedback forms are mandatory, as well as your participation throughout the course that we have taken into notice. We'll give you a completion certificate of this course that will be given by IAP. So Dr. Akash will take care of that. And thank you, Nagpur IAP, Dr. Shubda ma'am, Dr. Uday Bodankar sir, and all the office bearers of Nagpur IAP for allowing us to conduct this on this wonderful platform of Nagpur Pedicon. Thank you very much.
So as Mandar, go ahead.
So thank you so much, Dr. Akash, for conducting this work, bringing this workshop to AOP Nagpur. I must mention that Dr. Akash is our scientific committee co-chairperson for NAPCON, and it was his suggestion that we should conduct this workshop. And I am so glad that we could do it for IIP Nagpur. And we had an overwhelming response because we had an excellent faculty from Nagpur as well as from outside Nagpur. And it has been a wonderful 4-hour experience for me sitting throughout. It was so interesting with all the cases that you discussed. And thank you for this wonderful learning experience. I now request if you do not have any more instructions to give, Dr. Akash, can we conclude with vote of thanks?
Yeah, just 1 minute.
Yes, please. Please.
Yeah, so as Mandar rightly said, that there are two important things that we need to translate this into practice, and that will be the real achievement of this course. Second thing is, if you feel that this is very useful, encourage more and more people to attend this course in future and use this checklist. The third important thing is that, as they say, this is only trailer. The real ALS course is 2 days ALS course. So we are awaiting your presence on the other side of the pandemic for this 2 days course. For certification, please don't forget to submit the post test and feedback form. Thank you so much.
Yeah,
on behalf of Academy of Pediatrics Nagpur, I would like to thank Dr. A.K. Sharma sir, the national coordinator, Dr. Akash Bang, who brought this ALS-MAP course to Nagpur, and all the faculty, Dr. Manish Jain sir, Dr. Manish Doshi sir, Dr. Meenakshi Girish madam, Dr. Anjali Autif, Dr. Geeta Bhatt madam, Dr. Swapnali Bansode, Dr. Sakal Lad, Dr. Lakshmi Somawat, Dr. Ashish Lote, Dr. Mandar Deshpande, and Dr. Shomsekhar Reddy. I also like to thank our patron, Dr. Uday Bodankar sir, for gracing this function. And I would like to thank the team, our team, Yash and Nilesh, the IT team. And I will also like to thank Nivedita Patil, team. So thanking you, and then last, the delegates which made this program a success, thanking you. Okay, we now close the session. Thank you.
Right. Thanks.
We can close now, sir. Thank you.